So, good evening and warm welcome to friends and colleagues from India who have joined this webinar, and good morning to colleagues from US. And let me first introduce myself. I am Dr. Shyam Bansal. I am the Director of the Nephrology in Medanta Medicity, Gurgaon, and also the current Secretary of Indian Society of Nephrology. As you all know, that this webinar is jointly organized by Indian Society of Nephrology and American Society of Onconephrology. And why this webinar? Because you know that cancer is one of the leading causes of mortality in world, and there are a lot of research is going on in this field. And so there are many new therapeutic agents, and as a result of that, there's a drugs which are causing acute kidney injury, and cancer itself can affect the kidneys, and which will again increase the morbidity and mortality in these patients. So we have with us a panel of the expert today who will share their knowledge, research, and experience with us. And at the end of the webinar, I'm sure that all of us would be better prepared to take care of our patient with cancer and kidney disease. And so let me introduce you to the moderator of the session, Dr. Harish Seethapathy. He's an alumni of Madras Medical College, and currently he's an assistant professor of medicine at Harvard Medical School and a practicing nephrologist at the Massachusetts General Hospital in Boston. He is the co-chairman of the Education Committee of the American Society of Onconephrology and one of the program directors for the GLOMCON Fellowship and director of education for the Brigham and Women Hospital and MGH Nephrology Fellowship Program. So welcome to Harish, and up to you to take it forward.
Awesome. Thank you so much, Dr. Bansal, and hello, everyone. It's so exciting to see so many colleagues on the Zoom call. I do want to thank the leadership of ASON and ISN, particularly Dr. Bansal, for spearheading this. We have three fascinating topics to discuss today, and we really hope that these topics and the discussion that follows will provide a flavor of real-world onconephrology that will be useful to you when you are taking care of your own patients. But before we dive into the topics, I'd like to welcome Dr. Khenar Jhaveri, who will be providing an overview of the inception of onconephrology and where the field is today. Dr. Jhaveri is a professor of medicine and the associate chief of nephrology at the Donald and Barbara Zucker School of Medicine at Hofstra and Northwell. Dr. Jhaveri needs no introduction. He's a world-renowned educator in the fields of glomerular disease and onconephrology. He has an extensive track record. He's a true innovator in the education arena, right from the early days of running the AJKD blog, as well as his own blog, Nephron Power. And he now serves as the editor-in-chief of ASN Kidney News, which is becoming really popular too. He has published in top journals such as NEJM, JAMA, JAMA Oncology, KI, CJSN, AJKD, you name it. He's also, importantly, a co-founder of the American Society of Onconephrology and was the inaugural co-president along with Dr. Shruti Gupta. So welcome, Dr. Jhaveri, and we look forward to learning where onconephrology is today.
Hi, good evening and good morning, wherever you are in the world right now. And really thank the Indian Society of Nephrology to have this collaboration with the American Society of Nephrology to have this inaugural session to introduce a field that is very, very dear to my heart and a lot of people on this session. So it is the onconephrology introduction, and I have the honor to present the sort of the intro to the remainder of the sessions. And what I'll get to hopefully is to discuss what this whole field is all about, and when it started and where it's going. Just disclosures really pertinent to this is that Shruti and I were co-founders and ex-president of the American Society of Onconephrology. Really nothing else related to the topics. I really like to mention my mentor who got me into onconephrology when I was a trainee at Weill Cornell Medical Center in the city of New York City, and we would rotate to Memorial Sloan Kettering. And the person who really made me fall in love with onconephrology or cancer-related kidney disease was Carlos Flombaum. He actually was one of the first nephrologists, and is still there at Sloan Kettering Cancer Center, and started the division of endocrine and nephrology there many years ago, and really has been a pioneer in the field of cancer nephrology. So we'll take you through an introduction, a history of onconephrology, an overview of some clinical syndromes, and some of which will be touched on by our faculty today. And then what is the future in education in onconephrology? I think it's important that everybody understand, compared to say 10 years ago or even 5 years ago, definitely over 20 years ago, cancer it has become more beatable. And thank God to our amazing oncology, hematology colleagues who really spearheaded this, and there are more drugs coming out on a weekly basis to fight cancer. I wish we had similar things happening in nephrology, but I think we are decades, maybe even centuries behind from oncology. Because of the amazing stuff the oncologists and hematologists are doing, these patients are living longer, and the survivorship has increased. And as a result, you get complications of being alive with cancer and getting these drugs and their toxicities. And that's where nephrology comes into play. Just a bit of a history, and this slide we had created as part of an inaugural ASON editorial for Journal of Onconephrology to kind of give a feedback of the history of the field from, if you look on top, the research standpoint, awareness standpoint, and then education standpoint. If you go back in the 2007, 2005 world, that's when the first textbook was ever published by Eric Cohen. He's at NYU currently. On cancer and the kidney, there are a few articles. And then it's really not till 2009, 2010 when ASN did its first actual session on onconephrology, spearheaded by Wanchoo. And then there were some articles coming out in nephrology journals. And there was some increased interest in original investigations. Till then, there were mostly just review articles coming out in most of these journals. And in 2013 was the first one-day pre-course at ASN. But it's not till mid-2015, 2016 when you start seeing really the rise of original investigations, research studies in onconephrology, creation of the Journal of Onconephrology in 2017, and then 2015 onwards on yearly symposium in the US of onconephrology. And then in late 2018 onwards, there were actually a lot of nephrology journals having editors appointed to onconephrology and having a lot of sections in onconephrology. And 2018 was the first KDIGO onconephrology meeting. And eventually the interest built at least in the US, Europe world. And we decided to get together in late 2021 to form the American Society of Onconephrology. I'm going to go through a few syndromes that will highlight the importance of onconephrology, and one of them is acute kidney injury. And I think it's fair to say with any disease, when you have acute kidney injury, the mortality is very high and the morbidity is very high. And risk of AKI after cancer diagnosis is significant after the first year, and even more after 5 years, and worse when they're critically ill. But the causes, besides your usual pre-renal, post-renal, obstructive, the intrinsic causes in the cancer patient are very different. They could be thrombotic microangiopathy, which is our next session. It could be direct infiltration. It could be paraproteinemia, which is our last session, and then obstructive, nephropathy. But then there are these treatment-related complications that cause AKI, and that's one of the sessions we are going to have on checkpoint inhibitor. But there's a whole slew of other common chemotherapy agents like cisplatin and methotrexate that can cause it. And then you have AKI from electrolyte disorders that are true emergencies in oncology, like hypercalcemia malignancy and tumor lysis syndrome. So AKI in the cancer world is very, very important. And this schematic from Dr. Parazella, one of my other mentors, kind of summarizes that you can actually learn a lot of nephrology and pathophysiology by knowing every drug and their toxicities in the kidney. Look at the part of the nephron not affected. I think it pretty much covers the entire field of nephrology, from the endothelium, glomerulus to the collecting duct. You can name the drug and we can tell you where it can get affected. So it has not only taught us the toxicity part, but has taught us pathophysiology, and even just physiology basics, from some of these toxicities. Conventional chemotherapy nephrotoxicities you should be aware of. We're not going to be discussing this today too much, but most of you know cisplatin is nephrotoxic. And then there's these other drugs like ifosfamide, methotrexate, pemetrexate, and then gemcitabine that can cause kidney toxicity. And most of these cause, tubular, interstitial, or thrombotic microangiopathies. And this is something that has been pretty well established in the literature, and we won't be covering this too much into detail in today's session, but something to just be aware of. And as you know, the New England Journal of Medicine is really the New England Journal of Oncology, and every week you see a new drug popping up without us able to pronounce these names. And I think nephrology is getting there. We're also coming up with names we can't pronounce, but it's eventually just going to get unbearable in terms of knowing all of these. You just have to perhaps look it up on UpToDate and see which class it is. And that leads you to the targeted therapies, which are the bulk of chemotherapy or agents that we treat cancer with that directly affect a molecule that is affecting the cancer. And one of the classic examples of this is anti-VEGF or tyrosine kinase inhibitors. And I think our speakers in the next session will touch base a little bit on this because of the effect on the hypertension, proteinuria, and thrombotic microangiopathy. As you'll see, these drugs have specific effects depending on the class they are. So, this is another growing field of targeted therapies that has really revolutionized oncology, and their effect on the kidney can cause thrombotic microangiopathy or other tubular interstitial diseases. And this is a topic for today, which will be covered by our second session on immunotherapy-related acute kidney injury, which is a very popular agent to treat cancer. It uses the immune system to attack the cancer. So very smart thinking by the oncologist to use the immune system to unleash the brakes of the T cells to attack the cancer. But that leads to havoc in the immune system, causing inflammatory conditions and itises everywhere, from hypophysitis to nephritis, leading to acute kidney injury and even hyponatremia in rare cases. And CAR T therapies also revolutionized the hematology world, and there is some AKI as well with that. So this is another area that I think there's a lot of interest and a lot of research going on in the oncology world, along with the toxicity component of the toxicity world in oncology, cardiology, and other subspecialties. And you do see a lot of electrolyte disorders in our cancer patients. That's another area of clinical and research interest. The big one that has really stuck out and a lot of people are seeing is hypomagnesemia due to certain chemotherapy agents like cetuximab and cisplatin. And with the advent of SGLT2 inhibitors, maybe that might be something that we can use to treat it. There are other disorders on the divalent ions like hypocalcemia, hypophosphatemia that are much rare, but hypercalcemia malignancy particularly portends a very poor prognosis, and that has multiple different causes, but it's really PTHrP mediated or vitamin D mediated, but also local bone osteolysis. So it's very important to recognize that, because that actually is a cancer emergency, and a lot of those are in the ICU or in the hospital. The sodium and potassium dysregulation is another big component of onconephrology, and you do see a lot of hyponatremia, and a lot of that we have to be very careful on what the cause is. It's not always the same causes that we normally are used to seeing, especially when you get a lot of hyperosmolar contents of the infusions. And also the checkpoint inhibitors cause endocrinopathies that can lead to adrenalitis and hypophysitis causing hyponatremia. The one part I really want to highlight is we should not forget the pseudo-electrolyte disorders, and most of them are related in the cancer world. We often forget that these happen, and we might be able to diagnose an underlying cancer because of these pseudo electrolyte disorders. Classically, the pseudo-hyperkalemias, which are seen in myeloproliferative disorders, and then the hyperphosphatiemias and hyponatremias with malignancies like myeloma. And so this we have seen, and it's something that we should be very aware of in these patients. And thrombotic microangiopathy, I'm not going to spend too much time, but this is an entire session coming up that is going to go through the whole field of TMA and how that is affected from the cancer and the chemotherapy agents. But just not that, even stem cell transplants and post-organ transplant can cause TMA. And could this be related to malignancy or not? The other part of onconephrology is really the heme component. We shouldn't forget myeloma and amyloid as really part of onconephrology. And this schematic is later discussed in our third session that really talks about the circulating paraprotein and how it deposits in the kidney. You can get the tissue deposition like amyloid or Randall type light chain deposition disease, which you're used to seeing, but we're seeing more and more commonly non-Randall type deposits like PG and MID and monoclonal fibrillary or immunotactoid that can actually be associated with the paraprotein disorder, leading to a whole disease of called monoclonal gammopathy of renal significance, which will be discussed later today. Remember, also the circulating paraproteins more commonly cause tubular damage, which is cast nephropathy. But then if they don't deposit in the kidney, they can also cause an MPGN-like pattern without deposition, triggering complement causing C3GN or TMA. So you don't have to have deposition in the kidney from monoclonal gammopathies. You can still get GN from non-deposition diseases. And just another major component of onconephrology is stem cell transplant. And stem cell transplant can lead to AKI, CKD, and glomerular diseases. And that's an important component. And the GN component of this has been really studied well recently, showing that actually there's a FAT1 type of membranous that is specific to GVHD or post-stem cell transplant that happens with a membranous nephropathy. And then TMA is the most common GN post-stem cell transplant. Special groups have also been formed to have interest in onconephrology. At least in the US, we're seeing interest in pediatric onconephrology, where patients are living longer, and also the pediatric population seeing some of these toxicities. The transplant onconephrology world, palliative care, and oncohypertension. So just on a few things, oncohypertension is really growing in the cardiology world and nephrology as well. And you can see here the degree of hypertension that's seen with the different types of agents. Look at the RET kinase inhibitors, 43%, Bruton tyrosine kinase inhibitors, 71% get hypertensive. And a lot of them don't end up seeing a nephrologist, they end up seeing a cardiologist. And it's very tough sometimes to figure out what exactly is causing the mechanism. So these are some postulated mechanisms below. They could be from mitochondrial dysfunction, direct nephrotoxicity, decreased angiogenesis, high endothelin levels, and decreased nitrous oxide. The medications classically that work are ACEs, ARBs, calcium channel blockers, and thiazides. So it's important to understand this whole oncohypertension world. The other fascinating field is transplant onconephrology. We already know about pre and post-transplant malignancy screening and so forth, but giving a checkpoint inhibitor in a transplant patient is another challenge. I think that will be discussed briefly today at our session. And then what do you do with a patient who has myeloma and amyloid and they have end-stage kidney disease? Do you transplant them? And what are their outcomes? And what are cancer treatments post-transplant? There's a lot of emerging literature in this, and there's a whole field of transplant onconephrology. And finally, the field of palliative care, cancer and kidney disease is very, very important. When you have the burden of cancer and a burden of kidney disease, you are really dealing with end of life, and it's very hard sometimes to offer dialysis to a dying patient when the last rhyme of chemo, and that is going back to our basics of conversation and communication skills in teaching our physicians and fellows sometimes not to offer certain therapy in a dying patient, and that comes with training in palliative care. and what pain meds to use, and how do you treat the anemia in that setting, the fatigue. So a lot of this is also another part of onconephrology that is slowly growing. So this is sort of a summary of perhaps an onconephrology curriculum that should be included if someone is interested in broadening their knowledge and increasing their experience in onconephrology. It's not necessary that you have to see every one of these things, but to get a good breadth of experience, I think it's good to have what's listed here as a potential way to kind of learn onconephrology. So I just wanted to end with onconephrology education. And one of the things we had done a few years ago was, an Argentinian nephrologist and myself created a WhatsApp chat in 2019 to get a group of like-minded onconephrologists on there, and quickly it grew to close to over 118 physicians that were talking to each other about cases or sharing ideas and so forth. A few high school students here decided to study this more systematically. We found that when you got like-minded mastermind chats in a group together, we actually had a lot of themes that came out. It led to more collaboration. It led to better patient care because there was a lot of patient care discussions with experts, and there was a lot of knowledge sharing happening. Interestingly, after UpToDate, this chat was the next best resource. Why wouldn't it be? Because the up-to-date authors of some of those were on the chat, and you have direct access to them, and actually tackle difficult situations that you won't find on the chat, on the websites. So this really gave us a flavor of what what was going on around the world, and the hunger for onconephrology education, and the lack of experience, and the lack of just even the experienced physician has not seen certain type of cases. So these are so rare sometimes that you just learn from each other. There's no hierarchy here. It's just a very, very good way to kind of share and learn knowledge. So how do you get trained in onconephrology? Well, in the US, we have a 2-year nephrology fellowship. So either if you have a faculty within the nephrology fellowship that has expertise in onconephrology, you can create a track for your trainee that focuses on onconephrology, or there are a year extra fellowships in 5 or 6 programs around North America that you can spend an extra year focusing just on onconephrology, and I've listed those there. But I just wanted to end with a plug for our society, the Onconephrology Society. In 2021, late, I got a call from Dr. Shruti Gupta, who's actually going to be one of the speakers later, and said, hey, Khenar, this is really a fascinating field. Nobody's really formed a society. The growth is there. There's hunger for knowledge. We should really consider forming a society for onconephrology. With the help of Arash and Biru, the other 2 co-founders, right away, we collaborated and got this off the ground. The first meeting of the founding members, which were a group of 15 to 20 onconephrologists that are prominent in the field and had some experience with organizations, was in October. We reviewed articles and submitted the 501c3 paperwork, developed a logo and a website, and then also did an inaugural piece in Journal of Onconephrology to start the society, and then announce the creation of welcome members in January 2022. You're free to join the society. I think there are a lot of benefits to joining the society. There's education, there's research positions, there is a lot of committees you can join and promote and network with like-minded individuals. There is a monthly education series and an annual onconephrology symposium. So there's a lot of ways you can get involved and also learn from the society. There's a lot of positive vibes that happen. It's a very young society with a lot of energy and a lot of fun and good ideas to have an international collaboration. And I just want to highlight that this year's symposium will be at MD Anderson in Texas. I urge you all to attend. There's a virtual component as well, but if you're in the US, feel free to join. And the trainees, it's a discounted price as well. So I think it's worth trying to go to this if there's a lot of interest in onconephrology, not only to learn, but if you go physically there, you might meet some key experts and begin collaboration from both countries. And onconephrology in India, I found this article that just even the medications we'll be talking about today might not even be affordable to some of our patients in the Indian subcontinent. And, while we're discussing this, we should keep this in mind where, it's different in different parts of the world. When I spoke to a few experts and nephrologists in India and found that there's not really many experts in onconephrology in India and still in infancy stages. So we hope today's session will ignite energy and enthusiasm to join this wonderful young field and start clinical and research collaborations in India. So I really want to thank my Northwell Health Nephrology and Pathology Department, my Sloan Kettering mentors who inspired me to be onconephrology, and the multiple collaborators we have in the world in the field of onconephrology, and our founding members of the American Society of Onconephrology. With that, I think we have a few time questions, and then we'll go on to the next session.
Awesome. Thank you so much, Dr. Jhaveri. If anybody has any questions related to his talk, please put them in the chat box. But if there's any topic specific questions, we'll try to address them during the session. Okay, so I think, we'll slowly move on to the next session and we'll take the questions as they come. Our first session today is going to be on cancer and cancer therapy related TMA. And we have an awesome panel and a speaker, and I think we're going to love this discussion too. So I'm going to introduce you to them. Our speaker today is going to be Dr. Rimda Wanchoo. She's a professor of medicine at the Zucker School of Medicine and a full-time nephrologist at Northwell Health. She is, of course, one of the pioneers in the field of onconephrology. She's published extensively in the field, and we've all learned a lot from her. She is a very popular international speaker and one of the founding members of ASON. She also serves as an associate editor for JON and CKG. We have two other panelists to join Dr. Jhaveri to discuss TMA, the first of which will be Dr. Anuja Java. Dr. Java is a transplant nephrologist at the Washington University School of Medicine at St. Louis, and she's also the director of kidney transplantation at the John Cochrane VA Medical Center. Her research really focuses on defining the functional consequences of genetic variants identified in patients with complement-mediated diseases, including atypical HUS, C3GN, preeclampsia, etc. She is an elected counselor in the Women in Nephrology, or the organization known as WIN, and she is also the recipient of the 2022 National Kidney Foundation Award of Excellence for significant contributions to the field of kidney disease and the renal community. Our second panelist today is Dr. Sanjeev Gulati, who of course needs no introduction to the Indian audience. He is the president of the Indian Society of Nephrology and the principal director in the Department of Nephrology and Kidney Transplant at Fortis Healthcare. He has special expertise in managing kidney transplants and children with renal diseases. He's had experience from around the world, and he's played a pivotal role in the dialysis and transplant program at SGPGI Lucknow, which is among the largest programs in the country. He has presented papers at several international and national conferences and published more than 130 scientific papers in many reputed journals, including NEJM, KI, etc. He's also authored 20 chapters in textbooks, and of course, he's a household name in nephrology and has received several awards for his original contributions to the field of kidney diseases. So welcome, Dr. Gulati. And I think we will start off with Dr. Wanchoo's talk and then take questions as they come.
All right, so give me 1 second. I'll just share my, 1 second. Can you see my slides?
Yes, perfect. Thank you.
Okay,
Go ahead, please.
Yeah. So first, I'd like to thank the organizers for giving me an opportunity to present in this conference. It's always a pleasure to speak to audience in India because that's where I did my medical school and that's where I grew up. So thank you again for giving me this opportunity. So I will be speaking on cancer and thrombotic microangiopathy. I will start my discussion with just a couple of cases and sort of go through the presentation with the various salient features that we need to cover in this talk. So these are my disclosures, and I'll start the cases. So my first one was a patient who was 74 years old, who, hold on, just a 75-year-old woman who was diagnosed with stage 4 ovarian cancer, who was sent to me for evaluation of new onset of proteinuria. She had a history of metastatic ovarian cancer that had been diagnosed in 2013 and had received 8 cycles of paclitaxel and carboplatin, which had been completed in 2014, after which she had undergone surgery with hysterectomy as well as removal of her ovaries. A couple of years later, so in 2016, she developed new mediastinal and hilar lymphadenopathy. For that, she underwent resection. She received adjuvant doxorubicin and carboplatin for 6 cycles, which she completed in November of 2016. Then for the next 2 years, she received gemcitabine as well as carboplatin. And since 2019, she had been on bevacizumab, which is Avastin maintenance. So she came to me in August of 2021 because she was noted to have new onset of proteinuria. Her last dose of Avastin had been earlier in the month. She was otherwise a healthy woman, just with history significant for cataracts, osteoporosis, and neuropathy. She was really not on any medications. Her blood pressure was mildly elevated at 148/88, which was new because she really did not have a history of hypertension. Her exam was just significant for new onset of lower extremity edema. And these are her labs. She had some microscopic hematuria. And as you can see, she had a urine protein creatinine ratio, which was close to 15 grams. Her albumin was on the lower end of normal at 3.7, and her BU and creatinine were essentially close to normal. So I did the workup. I did some serological workup, ruled her out for infections. And as you can see, most of it was negative. Her LDH was marginally elevated at 243. And a serum immunofixation did reveal 2 IgM kappa bands, but her free light chain ratio was maybe just marginally elevated also. So I did biopsy that woman, and I will show you the biopsy in a little bit. But just as a summary, this is a woman who basically presented with nephrotic range proteinuria. And then I had another patient who was 63 years old, history of pancreatic adenocarcinoma, who was referred for worsening kidney function. He had developed cancer in 2018. At that time, he was treated with FOLFIRINOX, which was then changed to gemcitabine and paclitaxel since May of 2020, because he had developed some new omental lesions on the FOLFIRINOX. And while he was on the maintenance gemcitabine and paclitaxel, his kidney function had remained stable for about 6 months, with serum creatinine ranging, as you can see, between 0.7 to 0.8. And then just about 2 to 3 months prior to his evaluation with me, he had developed worsening kidney function. So we are in 2021 now. And his serum creatinine had progressively worsened. It had gone from 1 to 1.3 to 1.5. He did admit to taking NSAIDs occasionally, and he also was taking a really, really high oxalate diet. He was taking as much as 3 to 4 grams of vitamin C every day. His review of systems really was significant for just some fatigue, nausea, which comes with a lot of, patients who are on chemotherapy, some edema, and a weight gain. And these are his other histories. So he had undergone the Whipple's procedure for his cancer. He was on pancreolipase, with meals. He was on Lasix as needed for edema. He was on dexamethasone, which was usually administered with chemotherapy. And like I mentioned, he was on gemcitabine and paclitaxel. I actually, this was in the COVID time, and I did not physically see him, so there's no physical exam. It was a televisit, but I did get blood work, and his urine showed microscopic hematuria. He had large amounts of blood, but nothing in terms of proteinuria. His protein creatinine ratio was 0.1. And by the time I saw him, his creatinine had further worsened to about 1.8. His hemoglobin had remained relatively stable in the 9 range, which was sort of his baseline. His platelets were in the normal range, around 200, and his LDH was marginally up at 303. So this is another man who basically, in summary, presents with just AKI and really not much else. And I biopsied, and you'll have to take my word for it that both the patients essentially presented with the same sort of finding. And as you can see, this is light microscopy, where you can see double contouring of the basement membrane, some thrombus in the glomerular capillaries, immunofluorescence, which was positive for fibrin, and an electron microscopy, which basically shows the subendothelial widening. And the final read on both of these patients was chronic active thrombotic microangiopathy with minimal chronic changes. So Harish, would you like to take over?
Yeah, absolutely. I'll take over. I think those are two, I would say, typical and common presentations where we have complex oncological histories of patients, one with ovarian cancer, exposure to bevacizumab and nephrotic syndrome, and the other with, worsening cancer and no proteinuria, but does have exposure to gemcitabine. And I do want to ask the panelists, I'll start with Dr. Gulati here. TMA is such a broad umbrella. Like, just tell me your thoughts about the two cases, and what do you think when you see these patients?
Yeah, to be honest, the cases, although they have a similar histopathology, that pretty diverse, and it's very interesting to see that TMA is coming up. When we see drug-induced TMA, other than in onco setting, our first thoughts are to try and stop the underlying agent, which I'm not sure is always possible in a cancer kind of scenario. And then if things don't get better, then we use some other therapies like plasmapheresis, or even rituximab is available. So we've used those. But it's a totally different ball game. And as you rightly said, onconephrology in India is in infancy, and I confess I really haven't seen a cancer-associated TMA. We have had the AIN following immune checkpoint inhibitors, and we've had biopsies in these patients, but yeah, pretty interesting.
Awesome. Thank you, Dr. Gulati. I'm going to move on to Dr. Java. I know you've done a lot of work on sort of deconstructing what TMA actually means and, to define it further. So when you think about these cases, as well as other cases that you've seen in your practice, how is sort of your mental space when evaluating these cases, and how do you proceed through the workup?
Yeah, thanks, Harish. So that's right. Whenever we see, so TMA, of course, it's like a pathological diagnosis, but that's, we're looking at multiple etiologies here, of course. So whenever I see a TMA, in my mind, the first thing that comes to me is, am I dealing, I'm thinking about complement. Obviously, I'm thinking because complement is kind of the underlying pathophysiology, regardless of what is causing it in some form or the other. And so the first question that comes to mind is, are we thinking about a primary complement-mediated TMA, which is occurring due to a permanent dysregulation, if you will, as we see in genetic mutations and the classic hallmark AHAs? Or are we dealing with a transient overactivation of the complement, which can happen in a number of these secondary TMAs? And so what we're talking about today, the cancer, the drugs, and I know we'll talk about more, is that, I think more of that as the secondary, there is maybe a transient overactivation, because we know that a number of these drugs cause endothelial injury and then they can activate. So, the first thing in my mind is, how do I tease out between these two? What am I going to do next in terms of treatment? Of course, we know that when it's a primary process, you kind of reach out for the anti-complement therapy right away, versus when you're dealing with some of these secondary causes, you're trying to really get rid of the underlying etiology first and then maybe use an anti-complement agent. So I think the first thing is to kind of try to figure out what's the etiology and, how am I going to tackle it? That helps.
Awesome, thank you. Dr. Jhaveri, do you have anything to add?
Biopsy. This is why I think we should biopsy more, because the first patient, could have had, bevacizumab-induced portocytopathy too. I know it's very rare to see TMA with 14 grams, but it happens. And the second patient had a lot of risk factors for oxalate nephropathy. I mean, Whipple's procedure, vitamin C use. That's what I would have thought that patient would have had, but turned out to be TMA. So I think the value of a kidney biopsy and a kidney pathology is never going to go away. I think that's the key, and more you make these diagnoses, the more you can try to help our patients. Maybe sometimes it's not useful to do the biopsy because now we have to stop for cancer saving agent, but we might be able to still, salvage the kidney and still give the agent. So I think doing a kidney biopsy can always help here.
And I just want to ask another follow-up question to Dr. Wanchoo, and this was one of the questions brought up in the chat, was that, there were some subtle signs of systemic TMA, but was there more, meaning were there a lot of schistocytes in the blood, and were at any point in the clinical course of these two patients?
Actually, no, none of them. So I showed both of them, at least the second patient, the platelets, the hemoglobin, everything was stable. And honestly, I was not expecting to see TMA because there was really no protein. And from my experience of taking care of these patients, I've always seen some degree of proteinuria with TMA patients. So that to me was very unusual. And that's why I thought of presenting this, because I felt that these are two completely diverse sort of presentations. And even in the first one, I had no systemic signs. She had no anemia, no thrombocytopenia. The LDH it was really cheap. It was marginal. The haptoglobin was normal, nothing.
Harish, I just wanted to add that the renal limited TMA is far more common than systemic TMA. I think people need to realize that it's by far, we have seen more renal limited without systemic signs than the full-blown systemic TMA.
Yeah, that's totally been my experience too.
Yeah, no, and I completely agree with Khenar, because the reason, we don't think about renal limited TMA or it's underdiagnosed is because it doesn't present systemically. And a number of times, if you don't biopsy, going back to Khenar's point, you're missing some of these cases because, you may find it if you biopsy these. So I think it's kind of a gray zone because we don't really know the exact percentage of how many patients have renal limited TMA if they don't end up getting a true biopsy.
And yeah, I also want to point out that a lot of these patients have anemia, thrombocytopenia that may not necessarily be a TMA process, which may also sort of complicate, getting a biopsy done. But as these cases demonstrate, I think it's so important to get tissue, especially when you're deciding on future course of to give more treatment. And, I think Dr. Gulati brought this up at the start too, it's very difficult to decide what to do if you don't actually know the diagnosis. I think we'll move on. I think the other question was to differentiate between cancer-associated TMA versus cancer therapy-associated TMA. And I think Dr. Wanchoo is going to talk a little bit more about that in the coming slides.
Right. So I'm just this slide just shows how the TMAs, like Dr. Java just mentioned, it's a pathological diagnosis with diverse causes. So we can think of TMAs as primary as well as secondary. And amongst the primary, you can divide that into hereditary as well as acquired. And amongst the hereditary cause is, the TTP, which is the more common sort of TMA that at least the oncologists are also aware of, which is associated with ADAMTS13 mutation. Then you have amongst the primary TMAs, primary complement mediated disorders. So those will be in this setting, cobalamin deficiency mediated TMA is here, and DJKE mutation, which can also lead to TMA, would also be a an hereditary cause of primary TMA. Amongst the acquired primary TMAs would be essentially disorders which are characterized by the presence of antibodies. So if you have ADAMTS13 autoantibody present, or you have a complement-mediated disorder such as atypical HUS, but it's because of the presence of factor H antibody. So that would be in this section. And then you have the big setting of secondary causes of TMA, amongst which infection is a big one. And as we all know, the Shiga toxin producing E. coli associated HUS is the more commonly described entity that we're all aware of. But then there are other infections. HIV can lead to it, pneumococcal sepsis can also lead to it. And then in the lower right-hand bucket is TMA from a bunch of secondary causes. So here we have the malignancy-associated TMA, TMA associated with the use of drugs, the bone marrow transplant patient, the solid organ transplant patient who develops TMA, a pregnant woman who develops HELP and TMA, and certain glomerular diseases that can also be associated with TMA. So I'll be focusing obviously on the secondary TMA in this presentation. And this is just a pathology slide essentially showing the light microscopy as well as electron microscopy findings. Like I mentioned, there is thrombosis within the glomerular capillaries, there's thrombosis within the arterioles, there's subendothelial widening, which is as a result of endothelial injury, which in turn can lead to the double contouring of the basement membranes. So Harish, would you like to take over again?
Sure. I think this is one of my favorite questions, to be honest, because it's kind of like very nerdy. But any of the panelists may answer, why do some cases of TMA, you actually see the thrombus and you can, you see the image and it's TMA, whereas others, it's not a whole lot of like fibrin thrombi, but you could still have all the other changes of TMA, like the double contours and its angiolisis, and it's still, diagnosed as TMA, but there's not a whole lot of like thrombin formation or thrombus formation. So would any of the panelists like to weigh in?
I can weigh in. So from my experience and understanding, when we talk about a thrombotic microangiopathy and when you see a thrombus is more of an acute phenomena. And when we don't see that thrombus and we see a lot of, the microangiopathy and the endothelial swelling and the double contouring, those are more characteristic of more of a chronic or a subacute process. And actually for this particular reason, the KDIGO, I think it was the Controversies Conference that was in 2017, and in our more recent discussions at the NKF, and we've been talking about nomenclature, we've actually discussed this back and forth, that is thrombotic microangiopathy really a correct name, or should it just be called microangiopathy with and without thrombosis? And so that's an ongoing discussion in the field right now mostly, but in my opinion, it kind of differentiates a little bit between an acute and maybe a subacute chronic process. I'd be interested in hearing what others have to say.
So I have a very strong view on this, because I really hate the term TMA, because most of the cases do not have the thrombosis. I think they either have endotheliosis, like in preeclampsia or some of these drug-induced, or they have angiopathy. I think I'm speaking like how Dr. Ranke would speak, and I think I really believe the way he has taught this and in some of the lectures is it's either angiopathy or endotheliosis. And then you can have thrombi in addition, a classic with APLS, or in TTP, but TTP rarely affects the kidney. So it's only these autoimmune APLS lupus-like diseases where you really see the thrombi. And so really we should be calling it endotheliosis or angiopathy with or without thrombi. I mean, but really does it change management? I don't think so. So what's with the name? It's clinically still presenting as an MPGN pattern of injury. So I think that's the way to look at it. It's MPGN pattern without complement, like no deposition, no, anti-C3 or IgG. It's more just, posse immune MPGN pattern or something like that. That's the way to kind of think about it.
Awesome. Dr. Wanchoo, take it away.
Yeah. So how does one recognize thrombotic microangiopathy? And I think this is sort of, I just want to say that The classic description is that you have evidence of microvascular thrombosis, which mediates the organ damage, and then you also have systemic findings, which are associated with the intravascular hemolytic anemia as well as thrombocytopenia. And hand in hand with that is, evidence of hemolysis. So you'll have low haptoglobins, you have a high reticulocyte count, you have high LDH, and you'll have a negative Coombs test, and you can have schistocytes on the blood smear. Now, again, I think this has been mentioned before, and I think it's important for me to reinforce that you don't have to have the hematological manifestations, and you could still have a renal limited TMA. And just because you don't have this doesn't mean that that should not be a reason to biopsy. Once we have the classic TMA findings, it's important to exclude DIC. It's important to exclude the primary TMA syndromes, predominantly TTP. So measuring the ADAM-TS13 levels is important. And then, like I mentioned, the secondary TMA, it's, we have to rule out other autoimmune diseases, infections, so on and so forth. So coming to tumor-induced TMA and drug-induced TMA, which are the two topics that I'll cover in this talk, the management for tumor-induced TMA is really aggressive treatment of the cancer. And the drug-induced TMA, obviously, as the name implies, would be removal of the drug. And then, I guess, the supportive care and the other forms of treatment will go on. I'll talk a little bit about it as we go on with the presentation. So what are the tumors that have been associated with TMA? First of all, it's important to recognize that it's a rare entity. It's not something that's very common, but the tumors that have been associated are essentially GI malignancies. So stomach cancer is a big one, breast, lung, and prostate. Those are really the big ones that have been associated. Certain heme malignancies like lymphomas, non-Hodgkin's and Hodgkin's, and ALL have also been associated. So how do you differentiate? It's very, very difficult to differentiate this from, say, a primary, like a TTP or atypical HUS. Obviously you're obligated to rule out, check an ADAM-TS13 level, do complement testing. But when the patient presents, usually when you have a cancer-associated TMA, usually this is in the setting of a cancer which is pretty widespread. It's metastatic, or you may actually see it that you had a patient with cancer who's been treated, he's in remission, now presents to the hospital with, TMA findings, AKI, thrombocytopenia, and you'll actually see that the disease has come back. So there's recurrence of cancer. So I think that's something important to sort of remember, that in the setting of cancer, which is perhaps well controlled or is in remission, it's less likely the cancer that's mediating the TMA. And there have been some studies, again, the data is limited, but they did see that patients who had cancer-associated TMA did have a high incidence of bone pain. And maybe that's because of the tumor infiltration within the bone, and respiratory symptoms, which would be consistent with just having pulmonary TMA. So in terms of management, the response to plasmapheresis is actually poor. And patients with cancer and TMA versus patients with cancer and no TMA, the ones with the TMA do worse. So the mortality is worse. And now coming with cancer therapy associated TMA, as you can see, drugs can mediate TMA by two mechanisms. One is the toxic dose related. And in that, it's essentially a toxic reaction where the drug is causing a dose and time-dependent damage to the endothelial cells. And the traditional chemotherapeutic agents, such as mitomycin, gemcitabine, come in this category. The VEGF inhibitors, bevacizumab or Avastin is in this, and then calcineurin inhibitors that we see in our transplant patients. And amongst the immune-mediated TMA, essentially the mechanism is that the drug is causing the formation of antibodies, and that in turn is damaging the plates, because these antibodies are directed against platelets, endothelial cells, neutrophils, and that's the mechanism And the most common drug that's associated with this is quinine, which is the tonic water, but gemcitabine has been known to actually also cause immune-mediated TMA. So it causes the toxic, which is sort of dose and time dependent, but it's also been described to cause an immune-mediated. And these are just a list of the drugs that cause TMA and the mechanisms of causing it. And as you can see, it's sort of it's mostly direct toxicity, but the proteasome inhibitors, so bortezomib, which is Velcade, the ioxazomib, as well as quinine, these are the ones that are immune mediated. Now, quinine is not a cancer drug, but just to explain that proteasome inhibitors can cause immune mediated TMA. And kyprolis or carfilzomib is it's been pretty well described with that drug. And the others are direct toxicity or endothelial damage. And I'll just touch base on the vascular endothelial growth factor inhibitors or VEGF inhibitors because they are commonly used in our patient. Our first patient was on it. So the kidney effects of VEGF inhibitors are hypertension, proteinuria, as well as thrombotic microangiopathy. And this is a slide just showing, what is the sort of mechanism of action. As you can see, VEGF basically binds to the VEGF receptors. And, after that, it basically has intracellular signaling, and that is responsible for promoting angiogenesis. So if you use VEGF inhibitors, and it could be 3 types of VEGF inhibitors. So you have the VEGF antibody, which is bevacizumab. You can have soluble decoy receptors, which just sort of mop the VEGF molecule, which is a VEGF trap, which is aflibercept. Or you can have monoclonal antibodies, which are directed against the VEGF receptors. So in that is ramucirumab. So if you use these group of drugs, they basically inhibit VEGF signaling and cause anti-angiogenesis and a host of effects. Then VEGF receptors also has tyrosine kinase activity. So if you use certain tyrosine kinase inhibitors, they also will have anti-VEGF properties. And the TKIs that are responsible for this have been listed. So axitinib, sunitinib, sorafenib. And this is just a slide showing, how does hypertension happen? So what's been postulated is that when you have VEGF inhibition, you have increase in the level of endothelin, you have a decrease in the level of nitric oxide, there's enhanced salt and water retention, all of which will mediate hypertension. You can also see proteinuria, and the proteinuria could be as a result of both thrombotic microangiopathy as well as photocytopathies. And this is just essentially what I just spoke about, the pathology that's seen. So this is actually from the largest biopsy data that's there right now with these agents. This is a French study where they biopsied patients who had proteinuria and had been on either pure anti-VEGF agents or tyrosine kinase inhibitors. And the 2 most common presentations were thrombotic microangiopathy, as well as photocytopathies that I talked about, which included minimal change disease, as well as collapsing FSGS. And this is a table from that study. As you can see, 61 of the 73 patients were on bevacizumab, and 13 of the 21 were actually with minimal change disease and FSGS were on tyrosine kinase inhibitors. So the overall incidence of proteinuria in patients who are treated with bevacizumab ranges from 21 to up to 63%, but high-grade proteinuria, which is defined as 3+ on dipstick or more than 3.5 grams of protein, or nephrotic syndrome, it only affects about 2% of the treated patients. Amongst patients who are treated with anti-angiogenic tyrosine kinase inhibitors, the incidence of proteinuria, which is about 21 to 63%, but heavy proteinuria is reported in up to 6% of patients. So how do you work up a patient? You have these patients Like I mentioned, you have to check the Adam TS13. You have to, if they have diarrhea, you have to rule out sugar toxin, do stool cultures. You have to check vitamin B12 levels because, cobalamin deficiency can result in TMA. You have to go through a detailed history of medications, even family history, do Coombs test, check for antiphospholipid antibodies, which can lead to TMA, do serological testing to rule out diseases like lupus, and obviously rule out infections. And then, I think it's also important that we also do genetic testing, to do complement testing to evaluate if a patient has any sort of genetic defect, which may be acting as a trigger or a second hit that is actually mediating this TMA along with perhaps the drug. So I'll give this to Harish.
Awesome. I really want to spend some time on this because I think this is going to be super useful practically. Dr. Gulati, Dr. Java, Dr. Jhaveri, I'll move through each of you. Can you talk about the practicalities of complement testing at your center and any tips you may have when you send this testing?
Yeah, I think that's still a challenge to get all the complement factor analysis. We in India, very few centers do this, so there are centralized labs doing it. The general turnaround time for this is not less than 3 to 4 weeks. So that really impedes appropriate diagnosis and management. Certainly, how often it is useful? Well, as was pointed out, I would agree that you need to try and do it. The only complement we can just do complement factor, the C3, C4 levels, and that could give us a crude indicator, if I can put it that way. But doing the complete genetic testing is really a challenge, at least in most centers in India.
Dr. Bansal, you had a comment?
Yeah, so I think it was a very interesting talk. And then regarding this complement testing, so it's a challenge in India, but nowadays there are many labs who are doing it. And our patients, so what we do routinely, post-transplant TMA or the patient who have TMA as a diagnosis, in all these patients, we get the complement testing in our patient at least, because this is useful in the pre-transplant scenario. If you have thrombotic microangiopathy, it is important to rule out the complement disorder before you go for transplant, because the implications are there, and if you don't do it. But sometime you have a patient with end stage. So I'm talking in general about the complement testing in patient with kidney diseases. You have a patient with low C3 level who comes to you in end stage kidney disease. And that sometime if you do the testing and you find the variant of uncertain significance, that where it's actually the challenge. And then you don't know what to do, then you have to. So I would just like to know your comments, because I think you will be doing these studies in most of your patients, and how do you actually anticipate that if you don't have a known mutation, but then a clinical setting or a biopsy finding of TMA?
That's great. Yeah, I think that's probably the most, the question that's on everybody's minds. I'll direct that right to Dr. Java because, she's done a lot of work trying to match VUS to the phenotypes of disease. So Dr. Java, any insights you can give us on that?
Yeah, no, absolutely. This is something I'm extremely passionate about. I love doing this, and I do this day in and day out. So I'll begin with saying that when we're talking about complement testing in any kind of TMA, other than the C3, C4, like Dr. Gulati mentioned, none of the other testing is available right away, and it's not going to help you with an immediate diagnosis. The TMA has to be a clinical diagnosis on the bedside, whether you do a biopsy or you have heme parameters. Where complement testing really comes in is really for long-term prognosis, understanding, duration, really how am I going to manage this patient going forward? Because exactly, even here, when we do testing, it takes 2 to 4 weeks for it to come back. Now, when you're talking about complement testing, there are 2 different aspects to it. One is the genetic testing that a lot of you are alluding to, and the other is the antigenic testing. So genetic testing is when you're sending the sample and they're doing a genetic sequencing to look for mutations. And in our center, coming to the practical aspect, we do it in all our patients because we can do it on campus. Even then it takes 4 weeks to come back, but it's something that's easily orderable, it's done, and we do it. Now, when you get a genetic test report back and you get a VUS, like Dr. Bansal was mentioning, yes, we do have the expertise at our center to actually do functional analysis, structural analysis, and kind of understand what that VUS means. Even if you don't have that expertise, the first thing you should do when you get a variant of uncertain significance is figure out what protein is that VUS in. So if you have a VUS in, say, factor H or factor I, a very simple test to do next is to check an antigenic level of that protein, which is also maybe available locally. So if your VUS shows that your antigenic level of factor H or factor I is low, that VUS is very concerning for it to being deleterious. So, so it's kind of a stepwise process that you have to go through this. And then the other thing we do, again, not something I do right away because it's not available to us at our center, is some biomarker testing, where if I get a genetic testing and it's negative, and I'm still worried about that there may be complement activation going on, then we can send a set of biomarkers that include these complement split products, the IC3B, the factor B, BA, BB, to just kind of get a sense that is complement system active in this patient and at what level in the complement pathway is their activation going on. So that's been my general approach to complement testing for any TMA. Particularly for cancer or drug-induced TMA, I will say this, that the genetic mutations are found in a very, very small percentage, maybe 1%, 2%, if so. And there are case reports of, CFHR polymorphisms and mutations here and there, but it's not like the predominant underlying physiology for a number of these patients. We will still send it in our center, like I said, because it's convenient and it's practical.
Thank you so much for that insightful answer. Any other comments from our panelists? Okay, yeah, I think we'll move on. I think the second question was answered is that, it's very hard to find exact mutations or exact sort of answers for us to change management. And I think it's a science that is evolving, and hopefully we'll get more answers in the coming years. Dr. Wanchoo, take it away. I think we'll just keep moving.
So I guess the next question will be, Harish, do you want to take
this?
this?
Sure. I think this is a question that's often asked, by the nephrology community is, when should a nephrologist be involved in the care of a patient with VEGF inhibitors? When is the appropriate timing for a referral? And let's say, practically that a lot of oncologists may not refer them early, then what would be your advice to them in sort of how to monitor these patients? I'll start with Dr. Jhaveri here.
I usually tell oncologists to send the referral when they're adding the second antihypertensive agent. Because to me, hypertension is the first symptom of renal TMA. And I think cardiologists need to learn that, the oncologists need to learn that, and a lot of nephrologists still need to learn that. Because I don't believe hypertension causes kidney disease. I think kidney disease causes hypertension, or endothelial injury causes hypertension. And hypertension is the first symptom. So if they're actually on 2 to 3 medications already for hypertension, it's time for nephrology referral, not cardiology, unless the cardiologist will do a UA. Then I'll send to that cardiologist. But if nobody's doing the UA, look for protein hematuria, then don't send to that doctor. That's simple. The oncologist can do that too. It's simple. It's a UA. It's cheap. It's cheaper than these complement testings. And without a referral, they should treat these patients? I think they can easily treat these patients without referrals by treating the hypertension, like Dr. Wanchoo showed, and getting a urinalysis and rightly referring the patient if there's hematuria, proteinuria. I think there's a lot what I call the captain of the ship can do, the oncologist, way before the nephrologist or cardiologist sees the patient.
Any other differing opinions from the panel? Okay, I think we can move on to the next question because I think there's some more nuance here.
So when is the ideal? Yeah. So go on, Harish.
Yeah, so when is, I guess Dr. Wanchoo brings up this point, when is the right time to biopsy? And I know that even within the panel, and I know it personally, that there are some differing opinions of when to biopsy, whether it's purely based on the level of proteinuria or rise of creatinine. So I'd like to hear from everyone, like what would be your own personal threshold to biopsying this patient? And, this is not supported a lot in literature. So I really want to hear a personal opinion on, how you would pursue a biopsy and when you would pursue one. So I'll start with Dr. Jhaveri here and then move on to Dr. Gulati and Dr. Java.
I think AKI is definitely one. Proteinuria, probably, if it's uptrending, if I see an uptrending LDH, downtrending hemoglobin, and a worsening hypertension without kidney issues, I would also consider a biopsy. But that's one is very challenging because really the indication is very soft, but I found TMA in those cases too. But really it's the proteinuria that's uptrending, even if it's from 200 milligrams to 600, and the patient's requiring more blood pressure medications, then I would biopsy.
Dr. Gulati, would you agree, or would you do any different?
Yeah, I would agree, and we advise our oncologists to, monitor for proteinuria in these patients. And if we have two reports which are, uptrending, even at lower levels, we have gone ahead and done a biopsy.
Perfect, Dr. Java.
I actually agree with both of them because, we've just talked about it. So if it's safe, of course, there's not a bleeding risk with all the thrombocytopenia. I think it's important to biopsy regardless of, whether the proteinuria is nephrotic, non-nephrotic. You've talked about because there's renal limited TMA, you may be missing if the heme parameters are normal, and the number of other pathologies that come with this, the FSGS, the collapsing GN, interstitial nephritis, and all of that. I think that we'd be missing if we did not biopsy these patients. So I'm in agreement with that.
Hey,
Yeah, I
Harish,
also,
one caveat, is if the patient, this is a last drug and the patient has no other chemotherapy or target therapy options left and they're getting clinical TMA, then I wouldn't biopsy, because then maybe we just have to continue the drug with treatment or just stop the drug, and because it's the last line. And why are we biopsying someone who's it's a life-saving and there's no other line left, because then it's going to be it's a one-on-one decision in some cases.
Right, absolutely. I'll go to Dr. Bansal. Where's a comment?
No, so I was just so it's important to do the biopsy, but then if the kidney function is normal and somebody has only subnephrotic, means how you're going to manage it differently unless there's a deterioration of kidney function, or because doing a biopsy in kidney patients, especially in cancer patient, especially it's not easy, especially if there's some ascites or effusion, difficulty in doing a biopsy and the complications. So I agree with the more advanced sort of thing, but practically if only subnephrotic, obviously nephrotic syndrome is there, or AKI, renal dysfunction, and how you plan to change the management in those patients. Making a diagnosis important.
Yeah, I think that's why it's so good to hear differing opinions, because I think we all have different thresholds as to I want to know versus, there's other considerations. Dr. Shaikh, you had a comment too.
Yeah, I would absolutely agree with Dr. Bansal. We do not biopsy every patient with VEGF inhibitor-induced proteinuria or even TKI-induced proteinuria. At MSK, we have a ton of those patients. And the general approach is that if they're becoming proteinuric, generally speaking, if you hold the therapy, with TKI especially, you do see improvement in proteinuria fairly quickly in a few weeks, and that's sort of supportive of the whole diagnostic sort of dilemma. So, and then you can decide, do you want to challenge them with a different TKI? Do you want to use a lower dose? We've had situations where we've gone from 10 milligrams per kilogram or 15 milligrams per kilogram of Avastin or bevacizumab to even 7 or 5 milligrams per kilogram and managed to continue the therapy. Similarly, with tyrosine kinase inhibitors, we have been able to lower doses quite effectively, and patients have done well from a cancer standpoint. So I would highly argue against sticking a needle in every patient who develops proteinuria. We just saw 20 to 60% of patients will have some element of proteinuria. I don't think we will be biopsying all of them. I think the indication should be if there's a suspicion for something else that's causing it, some other pathology other than what we know. And if the patient's proteinuria is not improving or worsening, or of course there's severe kidney dysfunction, these patients are very hypertensive, sometimes even on several medications, and that too adds to the risk of the biopsy. So we do not routinely do biopsies in every proteinuric patient in TKI or VEGF inhibitor-induced proteinuria.
And actually, I think I'm sorry. Can I say? Yeah, I think I agree with what Dr. Shaikh just said. I personally also don't biopsy every patient. I will actually, a lot of times if they develop proteinuria, let's say 1 gram, 1.5 gram, which is sort of, and it's new, I will start them on an ACE inhibitor, titrate up the dose. But I think when it becomes that, they have a nephrotic syndrome, or if I feel that this could be TMA, then perhaps I might, I will biopsy actually. For like the first patient had nephrotic syndrome, that's the kind of a patient that because it's quite possible that the patient also can have a paraneoplastic G, and it's hard to differentiate, right, clinically what the patient might have. So I think subnephrotic, lower grade proteinuria, I also don't biopsy everybody. I will actually speak to the oncologist. I will start them on an ACE inhibitor. They usually have hypertension that goes with it. You can titrate up the dose. There's some sort of improvement. So that's my personal sort of way of also doing it.
Sure. Awesome. Dr. Trivedi, you had a related question.
Yeah, so my question here is that as Dr. Wanchoo just said that, how do we predict that whatever is this proteinuria or whatever are the other associated is going to be TMA? I mean, the patient could have a paraneoplastic glomerular disease, or he may have a disease process that is totally different from the oncology or from the cancer point of view. So don't you think that our threshold for a biopsy should be lower, and for these patients especially, because that the biopsy is probably going to help us not only diagnose but also prognosticate and decide whether the therapy is going to be ongoing?
Yeah, but a lot
Dr.
of
Gulati, Dr. Gulati, you had a comment. I'll let you answer
so we have our experience is anecdotal, but we have had a couple of patients where we biopsied at subnephrotic proteinuria, picked up acute interstitial nephritis, interestingly, and that helped us to convince our oncology colleagues to back off for a while, lower the dose, which I'm sure it would have been very difficult for them to do. Obviously, there's no denying that the risk-benefit ratio has to, you won't be biopsying patients who have severe thrombocytopenia, uncontrolled hypertension. But those who are relatively stable, mild proteinuria is going on, which is kind of increasing, my bias would be towards biopsying these patients. So at least we can, engage the oncologist to optimize the therapy or change the therapeutic agent if possible.
Yeah, I do want to point out that there's like 2 slightly different scenarios we're talking about. One is you just have the bevacizumab on board, and you see a very temporal rise in proteinuria with nothing else happening. That's the kind of patients that Dr. Shaikh and Dr. Wanchoo are talking about. Whereas there are other patients who might have also be on a checkpoint or had been exposed to a checkpoint recently or had other reasons to have ATN or AIN or any of these other causes. And that's when I think Dr. Gulati and Dr. Trivedi are pointing out that, you might want to lower your threshold for a biopsy. So I think we're all kind of having slightly different thresholds, but I think we're all, saying the same thing. So Dr. Shaikh, you had another comment? Sorry, you're muted.
Sorry, I didn't. I don't know why it's showing that way.
Okay, sure. I think we'll move on. I think the questions in the chat box are kind of similar. So I think we'll move on because we have some more material to cover before the end of the session. Dr. Wanchoo, please go ahead.
So, the data I just want to say is scant. The evidence-based guidelines for managing these patients is lacking. The cancer societies do suggest that one has to be monitoring for the development of proteinuria, but they don't really provide specific recommendations. And like Dr. Shaikh mentioned, yes, temporary withholding of the drug is helpful if the protein excretion is more than 2 grams. Perhaps holding the drug maybe permanently a patient who develops nephrotic syndrome or TMA would be the other one where you might want to hold the drug. But it's important to remember a lot of times screening isn't done. Oncologists are not checking UAs, and they sort of check it much later in the course of the disease. So it's important that as nephrologists that work closely with oncologists, that we really, really sort of collaborate and educate them on the importance. UA is so cheap, it's so easy, but you'd be surprised that it's not done as often as it should be. Obviously, the first thing to do is to discontinue the drug. If your confidence in the diagnosis of drug-induced TMA is really high, and you think that this is definitely the case, then maybe you don't really have to do any anti-complement therapy or plasma exchange. But a lot of times you see these patients early on, you have a lot of tests that are still pending. The ADAM TS13 level is not back, and the patient is deteriorating clinically. And perhaps at that point, you might, you can, if you think it could be possible that the patient has TTP, you might make a case for doing plasma exchange. So what about, Harish, you can take this one, anti-complement
I think
therapy.
this is a very common question about the use of eculizumab and in which scenarios and what kind of drugs, drug-mediated TMAs that you would use it for. So I'll start with Dr. Java. In your experience to use eculizumab, do you use any other agents other than eculizumab or any other treatments too? Love to hear what you've been using.
Right. I think it's like a continuation of what we said earlier, and also continuation of what Dr. Wanchoo was mentioning. I think there is no clear data on when to go for this drug. Like I said, the drug-induced, cancer-induced TMA are not your classic complement dysregulation, but there is complement activation. There are case reports of these patients responding. So, I think one clear scenario where you would want to reach out for this drug is when you don't have the potential to stop the underlying chemotherapy agent. You need that to go on. And I think that's kind of the real conundrum that we fall into. We stop the therapy, the cancer is going to progress, but we have a drug. We think that there is complement activation going on. We want to continue the chemotherapy. I think that is one scenario that I would definitely reach out, and I've done it before, where we want to keep the chemotherapy going and we use the eculizumab along with it. So that clearly is one scenario. And then, there's a lot of back and forth in the literature about what is the timing of it? Like, should we, if you're able to stop the drug, should we stop the drug and then wait and see if the patient doesn't respond? I think that's reasonable. What is the time frame? You don't want to wait too long, because if there is complement activation, early initiation, if after you've stopped the drug and things are not getting better, is more, the patient's going to respond better. So I think so. Those are my two things. If I think they can stop the drug, not responding, use it. You cannot stop the drug, add it on top to help. So that's kind of like a simplistic way of looking at it.
And I guess the big question is, when do you stop it? So I'll let the other panelists answer that too. Like, especially with renal limited TMA, when you have nothing to follow systemically, and maybe you do have some clinical signs to follow, like proteinuria or your creatinine, but when would you stop the eculizumab? And lastly, Dr. Gulati, I also want to hear the use of eculizumab in India. So we'll take these two questions one by one.
So, it's tough. I've used eculizumab in cancer therapy induced. My only concern is you're blocking the complement cascade, and could that hurt the cancer effect? Because you do need the complement cascade to fight the cancer. So I don't know. I don't know if that's been studied. So we just have to be careful, because you don't want to push the patient towards worsening pro-cancer effects. But we have had success where we used it simultaneously with the use of with eculizumab and the say Avastin or gemcitabine, so that they can get both treated. I have never used rituximab. I don't think the data on rituximab is very strong. Maybe in the post-stem cell transplant TMA, there might be some data, but not in drug-induced. At least the mechanism doesn't make sense here. There are a lot more options in post-stem cell transplant for TMA compared to drug-induced TMA. There are a lot of novel drugs people are thinking about there.
Absolutely. And Dr. Gulati, Dr. Bansal, maybe you'd like to weigh in on the use of complement inhibitors in India. How widespread are they used, and what's your experience been?
So eculizumab is not marketed in India, and it's available on a special license, prohibitively expensive. So I have no personal experience, but few centers all over the country, I think there is anecdotal experience where they could get it. I personally have limited experience with use of rituximab in an entirely different atypical HUS setting where we have used it as an additive therapy to plasmapheresis, and we have actually published this also, and we have found it to be beneficial. One of these patients was actually dialysis dependent, and just since we could not get eculizumab and he was not responding to plasmapheresis, so we used 2 doses of rituximab, and he became dialysis free. It's a dramatic improvement. But eculizumab is prohibitively expensive, not available only as a special license. Maybe Shyam Bansal, I think their center used eculizumab, Bansi. So Shyam, maybe you can share experience.
Yeah, thank you. So we have published the first case report of use of eculizumab in India, and it was the child, actually he was a US citizen, and that time it was not available, and we could get it through the embassy. And this patient later on responded, and we published this case report. The eculizumab, probably now it is available in India, and in other centers have used it in post-transplant scenario. But there is another experience from India where they have used it. So this thing, if ultimately you have to target the final pathway, if there is a complement activation which is going on, whether it is because of some drug, or whether it is because of the antibody mediated rejection, or because of the genetic complement abnormality, once it is activated, and then probably using eculizumab might be useful in any of the region, because that you are going to target the final pathway. And I don't have any personal experience of using this in cancer-related TMA or drug-induced TMA, but why not? Maybe once your pathology is taken care of, and once then you can probably, in these cases where there is a secondary involvement, you can stop it earlier, because there is not going to be persistent activation of the complement once the original pathology is taken care of. So your comment, because I am not expert in this field, just my thoughts.
No, that's great. Thank you so much. I think Dr. Wanchoo, I think we'll let you finish up the last few slides as we're running out of time.
So the evidence for the use of eculizumab in cancer drug-associated TMA is really very limited. It's limited to small case reports, case series. So just a couple of studies. There was a case series of 9 patients that had bevacizumab-associated TMA that was treated with eculizumab, and essentially all the patients actually had improvement in hematological parameters, along with stabilization or improvement of kidney function. And 2 patients in this series actually came off dialysis. Then there is some observational data from a French study wherein 12 patients had gemcitabine-associated TMA. And even amongst these patients who were treated with eculizumab, between complete recovery was seen in 17%, with partial recovery in 67%. And this is really a table just showing the use of eculizumab for gemcitabine-associated TMA. Again, like I said, it's just probably a total of 20 patients. And you can see that they had tried some Plex, steroids that had been tried prior to starting treatment with eculizumab. And the total number of doses are variable, but it's around, 4 to, I guess, 18 is like an outlier, but it's about 6 to 8 doses that patients get. And most patients actually did improve, both from a renal as well as a hematological standpoint. And this was a study that was just published this year in the management of use of eculizumab. It's a scoping review, so it is not a systematic review. And I think you have to take the results with a pinch of salt. But at least in this study, it showed that 80% of patients, so they actually looked at all drugs, primarily chemo, but they had like a couple of other non-chemotherapeutic agents also, but primarily it was proteasome inhibitors, bevacizumab, and gemcitabine. And they found that renal recovery was seen in 80% of the patients, and both renal and hematological recovery was seen in 60%. And almost 59% of patients came off dialysis. Again, I don't think this is great data. It is a scoping review, but I think it sort of gives you a sense of an overall impression of whether eculizumab works or not. And what about the treatment of cancer? Should we stop cancer treatment? There's really no data. There isn't data to support either way. And it also depends on, what is the cancer type, how late advanced the cancer is, are there other options available? And that has to be individualized, where you have to talk to the oncologist. And could you, if the patient can only take this particular drug for his cancer, this is the only thing that works, what about, I think this has been alluded to a little bit earlier, can you just continue the drug along with eculizumab? And this is just the data on gemcitabine-induced TMA and re-challenge. So you have a patient who develops TMA and you actually give them back gemcitabine. Does it always happen that the patient will have a recurrence of TMA? A couple of studies said, no, it's not. I mean, not everybody who has had it will reoccur. And in the last study, that's where this table is from, the patient actually had TMA. They were given back the gemcitabine and were given eculizumab along with it. And actually, the patient did reasonably well from a TMA standpoint, and actually did not have recurrence of AKI. The hematological parameters were stable, and they were able to continue treatment with gemcitabine. So this is really my last slide, and I'll just highlight the teaching points that TMA can be seen with both cancer as well as cancer treatment. The kidney manifestations include hypertension, proteinuria, and AKI. And diagnosis may be very important for prevention of rapid worsening of kidney function. The role of plasma exchange is minimal. There is perhaps a role of complement inhibitors, but the data is limited, and one has to remember that it's really limited to case reports and case series. And to re-challenge with the offending drug is a clinical challenge. And that's it. And that was my last slide. Thank you.
Awesome. That was phenomenal. Thank you so much for that amazing
Harish.
presentation, Dr. Wanchoo, and of course to our panelists, Dr. Java, Dr. Jhaveri, and Dr. Gulati, and of course Dr. Bansal too for weighing in. I think that made for a fascinating discussion. The panelists, if you could stay on and take some questions in the chat, that'd be super appreciated while we move on to our next session. And thanks everyone for your questions as well. But we're right on time, so I think we're going to move on to our second session, which I think will be as amazing as the first one. So now we're going to really delve into immunotherapy and kidney injury. And first up is Dr. Shruti Gupta, who's going to be giving us a lecture on both ICIs and kidney disease, as well as CAR-T therapy and AKI. Dr. Gupta is an assistant professor of medicine at Harvard Medical School and the director of Onconephrology at Brigham and Women's Hospital and Dana-Farber Cancer Institute. She's a physician scientist. She conducts epidemiological, translational, and interventional studies related to the nephrotoxic effects of cancer therapies, and her publications have appeared in leading medical journals, including the Annals, JAMA Internal Medicine, etc. Her research has also gotten a lot of press. It's been featured in the New York Times, the Washington Post, and CNN. And of course, to us, she's a co-founder of the ASON and was the inaugural co-president along with Dr. Jhaveri. We're so lucky to have her. I'm also going to introduce the other panelists before we move on to the lecture. So we have Dr. Natarajan Gopakrishnan, who again needs no introduction to the Indian audience. He's a professor at Madras Medical College and the director of the Indian Institute of Nephrology. Dr. Gopakrishnan heads the largest government-funded nephrology service in my own home state of Tamil Nadu in India. He's a highly accomplished teacher and has graduated more than 60 nephrologists under his mentorship. And he's also won the ANIO Award for Service Excellence. He's a prolific scientist and has published 145 articles in reputed journals, including, I want to point out, the most recent clinical trial on the use of steroids in infectious GN that was published in KI Reports. It was one of the best examples of how to conduct a trial in low resource settings, so congrats on that. He's also the chairman of the Scientific Committee of the Indian Society of Nephrology and the chairman of the research board at the MGR Medical University of Tamil Nadu. And we have Dr. Aisha Shaikh, Dr. Shaikh is an associate professor of nephrology at the Memorial Sloan Kettering Cancer Center in New York and holds a faculty appointment at Weill Cornell Medical College. Her clinical and research interests are in onconephrology and interventional nephrology. She's a counselor of the ASDIN, which is the Interventional Nephrology Society, and also the co-chair of the Training and Workforce Committee of the ASDIN. She's, of course, a master educator. I've learned so much from her. She's phenomenal at making complex topics more palatable through her tutorials and her lectures. And also to point out, she's a member of the ASON Research Committee and a faculty member of GlomCon, and she's very popular there as well. So welcome, Dr. Shaikh. And we also have Dr. Ala Abudayyeh. She's an onconephrologist at the MD Anderson Cancer Center and director of the clinical research at the division there. She's a nationally recognized expert in both immunotherapy-induced nephrotoxicity as well as stem cell transplant-related kidney complications. She's been voted as a co-chair of the research committee in the ASON, where she leads a wide, diverse group of onconephrologists internationally in developing the field further. She's co-authored multiple publications as well as book chapters and also contributed to the onconephrology curriculum for the American Society of Nephrology. And of course, she's contributed to the first guidelines on the SITC Handbook on Nephritis Management and established the first institutionally accepted nephritis algorithm at MD Anderson Cancer Center. So such an amazing panel. So welcome all of you. I'll hand it over to Dr. Gupta to start with the lecture, and then we'll discuss a couple of cases to really get into the nuances of the practical management of ICI-related nephritis.
Great, thank you so much. First of all, can you see my screen?
Yes, perfect.
Okay, great. Okay, well, thank you so much for the invitation to be here. It's really exciting to see these collaborations between ASON and ISN, and I hope that it's the first of many. So today I'm going to talk about updates on the diagnosis and management of ICPI and CAR-T related AKI. These are my disclosures. And here are our learning objectives for today. So I'm going to talk about ICI-AKI and in particular some of the clinical features, risk factors, and outcomes. I'll talk about this perennial debate about whether we biopsy or we don't biopsy. I will say a quick word about triplet therapy and lung cancer, but we'll save that actually for some cases later on. And then I'll say a quick word about corticosteroid duration, which is also a matter of some debate in the treatment of ICPI-associated nephritis. And then an even quicker word about kidney transplant patients. And so this is going to be a little bit of a whirlwind talk, and we'll be trying to cover a lot of ground. And then I'll finish by spending a few minutes talking about CAR-T-associated AKI and electrolyte abnormalities. And I know that in oncology, there's all these acronyms, and it can sort of seem like it's an alphabet soup of different therapies and can make your head spin a little bit, but hopefully we will demystify some of these therapies today. Now, you probably are all well aware that immune checkpoint inhibitors have sort of transformed the landscape of therapy in oncology, and the number of trials even incorporating immune checkpoint inhibitors has skyrocketed since 2014. And as a result, there's also been a market increase in the global market revenue associated with these drugs as well. And in order to understand, how these drugs lead to what we call immune-related adverse events, it's important to understand their mechanism of action. And so a tumor cell releases antigens that are taken up by antigen-presenting cells. And then these antigen-presenting cells present these antigens to a naive T cell, thereby activating them. And the interaction between PD ligand 1 on the tumor cell and PD-1 on the activated T cell leads to inhibition of the immune response. And similarly, the association or interaction between CTLA-4 on the T cell and CD80 on the antigen presenting cell leads to inhibition of the immune response. And so what these drugs, anti-PD-1, anti-PD-L1, and anti-CTLA-4 do is they inhibit this inhibition, and they release the brakes on the immune system and allow the immune system to fight off the cancer cells. But despite all of the excitement surrounding these drugs, they are associated with what we call immune-related adverse events, or IRAEs. And you can see that this can manifest as inflammation in a variety of different organ systems. And the kidneys are not spared. And the first case series of immune checkpoint inhibitor associated AKI, or ICI-AKI, were described back in 2016. One was led by my colleagues, Dr. David Leaf and Cortisar here at Brigham and Mass General, where they looked at the histopathological features of 13 cases of biopsy-proven ICI-AKI, and they found that 12 of the 13 cases were acute tubulointerstitial nephritis, or ATIN. And then there was another series led by Dr. Shirali's group at Yale that also found that 6 of their 6 patients who were biopsied had ATIN. And so what we knew from these initial studies was that ATIN was likely the most common lesion. But then there were other studies that soon followed, including this one led by Dr. Abudayyeh, who we're lucky to have join us today. And her center actually looked at all patients treated with ICPIs between 2008 and 2018 who had been biopsied for AKI. And so what they found was that of the 16 biopsied patients, 14 of them had ATIN, but the ATIN co-occurred with glomerular lesions in 9 of those cases. And you can see the variety of different histopathological manifestations here. And this is just a reminder that not all ICI-AKI is AIN, and that's why we often pursue biopsies in atypical cases. Now, another question that came up early on was, well, how do we actually know that the ICI-AKI is truly attributable to the immunotherapy, and how much of it is actually attributable to the immunotherapy? And so Dr. Seiss and Dr. Seethapathy actually looked at this, and they looked at 1,843 patients who were treated with ICPIs between 2011 and 2016. And they found that any AKI was common, occurring in 17% of the patients. But sustained AKI was less common, occurring in 8% of the patients. And then when they actually manually chart reviewed the cause of AKI in those patients, they found that only 3% of the patients actually had AKI that was truly ICPI related. And so this highlights the conundrum that we face when we're taking care of these patients, where how do we actually differentiate without a kidney biopsy what the cause of the AKI is? And so more to come on that. And so, until recently, what we knew from these case series was that the incidence of ICI-AKI was probably somewhere between 2 to 5%. We knew that the most common histopathological lesion was AIN. And we also saw in our clinical practice that ICI-AKI can have major repercussions, and it can lead to the discontinuation of potentially life-saving therapy, irreversible loss of kidney function, and prolonged courses of immunosuppression, usually in the form of steroids. But existing data was largely limited to single center case series. And the most important question for our oncology colleagues is, well, is it safe for me to actually re-challenge a patient who's developed ICI-AKI? And we had very limited safety data on that. And so in 2020, Dr. Leaf and Dr. Cortisar led a multi-center study where they actually looked at 138 cases of ICI-AKI and 276 controls from 18 institutions. And this was the largest study to date at that time. There were limitations though. So 17 of the 18 institutions were from within the United States. They included patients with moderate to severe AKI only. There were only 60 patients that were biopsied and only 31 that were rechallenged. And so because there were a number of key questions that remained unanswered, we actually decided to conduct an even larger international multi-center study. And so we collected very detailed data on 429 patients who were diagnosed with ICI-AKI from 30 sites across 10 countries. And this was truly a grassroots effort, unfunded. We just contacted collaborators, hematologists, oncologists, nephrologists from around the globe. And we collected very detailed data on demographics and comorbidities, concomitant treatment with medications like proton pump inhibitors and nonsteroidal anti-inflammatory drugs, prior or concomitant IRAEs, laboratory and kidney biopsy data if available, treatments that patients got for their ICI-AKI, and important outcomes like renal recovery, what happens after rechallenge, and overall survival. And we defined AKI using one of two criteria. So patients could either have a more severe increase in their creatinine from baseline, like a doubling from their creatinine, or they needed renal replacement therapy. Alternatively, they could have a lesser rise in their serum creatinine from baseline, but they had to have one of these three things, one of these three characteristics. And the reason for doing it this way was we wanted to truly ensure that we were capturing ICI-AKI and not AKI from other causes. We also wanted to study risk factors for ICI-AKI, and in order to do this, we collected data on control patients who received ICPIs contemporaneously, but they didn't develop ICI-AKI. And so these were patients who, quote unquote, were allowed to develop AKI because we didn't want to introduce bias or confounding, but they just couldn't develop ICI-AKI. We also collected data on renal recovery, which we defined as a return of the serum creatinine to within 1.5-fold times baseline. So here are our results. So we found that ICI-AKI developed at a median of 16 weeks after initiation of the ICPI. And there's a lot of heterogeneity in the timing, with 10% of patients developing ICI-AKI more than a year after the initiation of the drug, which tells us that the timing is really not helpful in helping us decide whether it's from the ICPI or not. With regard to the severity, most of our cases were stage 2 or stage 3 AKI, and 33 of our patients needed dialysis. There's probably some degree of selection bias here, though, because those are the cases that were selected by our collaborators. We also wanted to see whether urinary findings are sensitive or specific for the diagnosis of ICI-AKI. And we found that 40% of patients had greater than or equal to 1+ blood on their urinalysis. 41% had greater than or equal to 1+ leukocyte esterase. And we found that 62% had a urine protein to creatinine ratio greater than or equal to 0.3. And so what that tells us is that no, we cannot rely on a urinalysis to tell us whether a patient has ICI-AKI. And I can't tell you how many cases I've seen now of patients who have a urinalysis that's completely bland and there's no abnormal cells, and then I biopsy them and they have raging interstitial nephritis. And so that's another important thing to keep in mind. We also looked at the frequency of extrarenal IRAEs and found that they were very common, occurring in over half of the patients, and rash and hepatitis were the most common. And then when we looked at our biopsied patients, we had a pretty sizable cohort of patients who were biopsied, 151, and we found that over 80% of the patients had ATIN, and this is a representative image of a patient with ICPI-associated AIN, and you can see sort of the sea of lymphocytes that's so characteristic of this phenomenon. But importantly, up to 20% of patients did have other lesions on their biopsy as well. When we looked at risk factors for ICI-AKI, we found that having a lower baseline EGFR, prior or concomitant proton pump inhibitor use, and prior or concomitant IRAEs were each independently associated with ICI-AKI. When we looked at treatment, we found that the majority of the patients were treated with steroids, which is probably not that surprising given that the most common lesion was AIN, and we found that 100 patients received IV pulse dose steroids. When we looked at renal recovery, fortunately, renal recovery occurred in the majority of our patients, around 2/3. And when we looked at predictors of renal recovery, we found that patients who were treated with steroids were more likely to have renal recovery, whereas patients with more severe AKI were less likely to have renal recovery. We then conducted a sensitivity analysis that was limited to the patients that were treated with corticosteroids. And importantly, we found that early treatment with corticosteroids within 3 days of the diagnosis of ICI-AKI was associated with a higher odds of renal recovery. And so this is important. It means that we shouldn't dilly-dally when we're trying to make the diagnosis. We should biopsy or treat empirically, as quickly as possible so that, these patients have a shot at having renal recovery. Now, our most compelling data was on recurrent ICI-AKI after rechallenge. And we had 121 patients who were rechallenged. And interestingly, fewer than 1 in 5 developed recurrent ICI-AKI. And of those patients that did, half had renal recovery. And so I actually do now really encourage the oncologist to try to put patients back on their immunotherapy whenever possible. And so I do think that this data is very, very helpful in kind of guiding that practice. Now, there were limitations to our study, like not all of the patients had a kidney biopsy to confirm the diagnosis, but that also reflects our real world practice where we often don't biopsy everybody. And we didn't collect data on oncologic outcomes. Now, a key question that sort of has come up, that wasn't answered by our study either is, well, how do we actually know that AKI in a patient on an ICPI is directly from the ICPI? And I just showed you that there are really no clinical or laboratory features that can help us make this diagnosis. And so then the question is, well, how do we know when to biopsy? And there's a lot of debate about whether to biopsy these patients or not. And we had a very excited debate about this during our Onconephrology symposium at Brigham and Dana-Farber in the fall, where some people say that we should biopsy almost everybody with suspected ICI-AKI, and others say that we should treat empirically and see if the patients get better. I tend to fall under the camp where I pursue a kidney biopsy whenever feasible, unless it's really a slam dunk for nephritis, like they've been on a PPI, they've got eosinophilia, they have other extrarenal IRAEs, because the biopsy is not just helpful in making the diagnosis, but it also can help from a prognostic standpoint. It'll tell me how severe is the AIN, is there a lot of scarring? So that information is very, very important. Now, what's interesting though, is that when you actually look at the cancer guidelines, they say that you should consider a kidney biopsy only in the setting of very high elevations in serum creatinine. They also say that you should permanently discontinue immunotherapy in patients with high elevations of their creatinine. But I just showed you data that suggests that we really can be rechallenging a lot of these patients. ASCO similarly says that we should permanently discontinue an ICPI in the setting of severe AKI. And they say that a kidney biopsy should be discouraged until corticosteroid treatment has been attempted. Now, finally, in 2021, the Society for Immunotherapy of Cancer actually included a nephrologist in making these guidelines, Dr. Cortisar, and they said that given the lack of specific clinical features for ICI-related AKI, a kidney biopsy should be strongly considered when feasible. And so it was really nice to see oncologists and nephrologists kind of working together to make these guidelines. Now, we know, though, that based on Dr. Seethapathy's data that we can't biopsy every patient that walks in the door, all 17% of those patients that develop AKI at some time point. And so what we really need are non-invasive biomarkers, particularly in those patients where they have a solitary kidney, they're on therapeutic anticoagulation, and we don't feel comfortable stopping it. And so there was this study led by Dr. Moladina and Dr. Chirag Parikh's group at Yale in 2019. This was mostly a non-cancer cohort, but they measured levels of urinary T cell cytokines and found that patients with AIN were more likely to have elevations in urinary TNF-alpha and IL-9 compared to AKI and CKD from other causes. And so Dr. Sandra Herman at Mayo measured these cytokines and others in the urine of patients with and without presumed ICPI-associated AKI, and they found that IL-2, IL-10, and TNF-alpha were actually consistently elevated in the urine of patients with ICPI-associated AKI. But again, these are studies that need to be replicated, I think, on a multi-center and much larger scale. Now, another really interesting study was led by my friend and colleague at Mass General, Dr. Megan Seiss, where they had this very interesting hypothesis where they said that because ICPIs block immune checkpoint pathways that include those that are blocked in patients with like congenital CTLA-4 deficiency, that maybe some of the same biomarkers that are elevated in patients with congenital CTLA-4 deficiency would be elevated in the plasma of patients with ICI-AKI. And one such biomarker was soluble IL-2 receptor. And they found that a cutoff point of 1.75-fold above the upper limit of normal was highly diagnostic for ICPI-associated nephritis when compared to AKI from other causes. And so, I and Dr. Seiss are looking at this on a larger scale as well, and also tracking changes in soluble IL-2 receptor levels over time. Now, I did want to just mention briefly another area of some controversy, which is corticosteroid duration. And, I think until we have a clinical trial, we sort of have to use observational data to guide us. And if you look at the oncologic guidelines, they say that you should taper steroids over 6 to 8 weeks. But that's a long time for patients to be off their immunotherapy, and they might be prone to side effects. And so we actually used our multi-center study to look at patients who were treated with a shorter duration versus a longer duration of steroids. And we found no difference in the rates of recurrent ICI-AKI or death in the 30 days following the steroid taper. And so until we have data from an RCT, I do use this to guide my practice. Excuse me. Now, I do want to say a quick word about another special population, which are our kidney transplant patients. And my friend and colleague, Dr. Murakami at the Brigham, conducted her own multi-center study of 69 kidney transplant recipients who were treated with ICPIs. And she looked at the incidence of graft rejection in patients who were treated with ICPIs compared to historical controls. And she found that the incidence of rejection was 42% in patients who were treated with ICPIs, and found that of those, 19 actually lost their allograft. And factors that were associated with a lower risk of rejection included mTOR use and triple immunosuppression. Now, since then, there have been a number of studies that have found sort of conflicting data. I think there's a lot more to kind of come in this area. Dr. Murakami and others are working really hard to give us better data in the transplant population. And so I would just sort of stay tuned for that. Now, we have a number of other sort of planned studies in this area, including whether PET CTs can be used for the diagnosis of ICI-AIN. A number of us are doing some other biomarker studies, and we're also planning an RCT comparing treatment regimens and durations for ICI-AKI, including the role of second-line therapies like infliximab and tocilizumab. All right, so the last 2-3 minutes, I just want to talk about CAR-T-associated AKI, which, like immunotherapy, has really dramatically transformed the landscape of treatment of hematologic malignancies. And there have been over 1,200 clinical trials testing cell therapy since 1993, with most of these actually being related to CAR-T therapy. And the indications for CAR-T are expanding. It used to be just approved for pediatric ALL and adult refractory DLBCL, and it's now being used in solid tumors, multiple myeloma, and it's even being tested in non-cancer indications like in lupus patients. And so it's really incumbent on us as nephrologists to be aware of some of the side effects associated with these therapies. Now, how is CAR-T actually made? Well, you first extract a patient's red blood cells, and then once the red blood cells are taken out, the T cells are separated out via apheresis. And then once these T cells are isolated, they are genetically engineered using a viral vector to produce chimeric antigen receptors on their surface that allow them to recognize and bind to the tumor antigens. And then these are expanded into hundreds of millions of cells and then infused back into the patient, where they can then destroy the resistant cancer cells. Now, before patients get CAR-T, they usually get lymphodepleting chemotherapy in the form of cyclophosphamide and fludarabine, which is supposed to help promote in vivo expansion of these CAR cells and improve their efficacy. Now, like immunotherapy, this therapy is associated with side effects, and that includes neurotoxicity and the dreaded cytokine release syndrome, which is very, very common and occurs in over 90% of patients treated with CD19 CAR T in clinical trials. And patients present with high fever, fatigue, and body aches in the days following the initial infusion. And in its most severe form, patients can progress to multi-organ failure and AKI. And patients who are at risk for CRS or are showing early signs of CRS are usually treated with tocilizumab, which is an IL-6 inhibitor, and dexamethasone. Now in 2020, because we were seeing so many cases of AKI in the setting of CAR T, Dr. Seethapathy, Dr. Saiz, and I actually decided to look at this at our institution. And so we collected data on 78 patients treated with CAR T at our institutions and looked at the incidence of AKI and how these patients fared. And we defined AKI based on modified KDIGO criteria. And we further chart reviewed the patients as having AKI that was prerenal in the context of CRS, ATN, or obstruction. We also looked at the incidence of hyponatremia, hypokalemia, and hypophosphatemia, as well as length of stay and 60-day mortality. And so when we looked at those 78 patients, we found that CRS was very common, occurring in 85% of the patients. And of these, 62% received tocilizumab. AKI was very common in our cohort, occurring in nearly 20% of patients. And 6 patients had stage 3 AKI. And 3 of those 6 patients needed dialysis, and 2 of those 3 died within 24 hours of actually initiating dialysis. We then looked at the association between AKI and CRS and found that most of the patients with prerenal AKI or ATN had some degree of CRS. And we found that patients with higher grades of CRS had a 9.8-fold higher odds of developing AKI. We found that 60-day mortality was exceedingly common among those patients that developed ATN. And when we looked at the electrolyte abnormalities, we found that hyponatremia was very common, occurring in over half of the patients within 30 days. And we don't have any idea why these patients develop these electrolyte abnormalities. We can only speculate that maybe it's SIADH from the lymphodepleting cyclophosphamide or a rise in vasopressin levels occurring in the setting of elevated IL-6 levels. Hypokalemia was also very common, and we speculated that this might be due to elevations in cortisol or a global renal tubular defect. And interestingly, hypophosphatemia was the most common electrolyte abnormality, and we speculated that this might be due to an IL-6 mediated increase in FGF23 levels. But what we really need are urinary studies so that we can actually confirm some of these theories. Now, since our study, there have been others that have looked at the incidence of AKI from CAR T with variable findings, including this study from MSK, where they actually found that the incidence of CRS was similarly high, as was the incidence of AKI, but their patients fared better. None of their patients needed dialysis, and most had renal recovery within 30 days. There's also some thought that different formulations of CAR may be associated with lower rates of AKI. I'm not even going to try to say that name over here on the slide, though. We also think that there may be lower rates of AKI that might be due to earlier and more widespread use of tocilizumab and dexamethasone as people start to manifest with early CRS. So with that whirlwind, I wanted to say thank you to Dr. Leaf, Dr. Saiz, my collaborators and mentors at Brigham and Dana-Farber and Mass General, our 100+ ICI-AKI collaborators, and ASON leadership for inviting me. It's really exciting to see how this society has grown since Khenar and I first founded it 2 years ago. So thank you very much.
Thank you so much, Dr. Gupta, for that fantastic talk and all that hard work that has gone into making those studies possible with so much collaboration, which I think is sort of the exciting part about onconephrology, both research and clinical. So I think we're going to discuss a case or two. So let me see if I can share my screen. These cases are from Dr. Gupta. And I really sort of want the panelists to weigh in on practical aspects of the management. There's a lot of, golden points in Dr. Gupta's presentation that I think we can use for this case. So let me start off by asking the panelists questions from this fascinating case. This is a 61-year-old gentleman who has a history of bladder cancer on pembrolizumab. and also has a past history of DVT on apixaban, who's now presenting with acute on chronic kidney injury. So this particular patient was diagnosed with urothelial carcinoma 1.5 years prior to presentation. Initially was exposed to gemcitabine and cisplatin, and of course, as you see in many cancer patients, had a multitude of complications. One of which was had a big large bowel obstruction, so had diverting colostomy, so was off treatment for a little bit of time. And 1 year prior to presentation, had 2 other events that happened at the same time. One of which was developed bilateral urethral obstruction and hydronephrosis requiring PCNs, and also had a DVT and had to be started on apixaban. So 4 months before he presented to the renal clinic, he stopped the gemcitabine cisplatin because he didn't really tolerate the side effects and was started on immunotherapy. 3 weeks prior to presentation, the serum creatinine almost doubled from a baseline of 1.2 or 100 millimole per liter to 2.1 or 185 millimole per liter. So further pembrolizumab was held, and we are looking at this patient right now where the serum creatinine has doubled, has been on pembrolizumab for 3 to 4 months, and now has come into the renal clinic with AKI. When you look at other history, there's not a whole lot of history there that's significant, but I will point out the UA findings that this patient had 3+ blood, 2+ protein, numerous RBCs, WBCs, and clumps. And if you look at the UPCR ratio, it was 2.0, which is like gram per gram. No hydronephrosis, already had the PCNs, and nothing else really sort of stands out from other history. So these are the medications, apixaban, mirtazapine, and multivitamin. And nothing stands out in the exam except that I would say that this patient has a high BMI of 40, but no other significant findings on exam that is not otherwise expected. Here are the initial labs for this patient. Has a little bit of anemia with a hemoglobin of 9.8, platelet counts okay. The creatinine was, as I mentioned before, and if you look at the differentials on the CBC, this patient does have slightly elevated eosinophils at 8.7%. No other electrolyte abnormalities except for slightly low potassium. So I'm going to ask the panelists here, and I'll start with Dr. Goplakrishnan. What are your thoughts on this patient? Like, if this patient comes to your clinic, what would be a next step in management? And I also want to hear an Indian perspective on the kind of patients that you've been getting who have been on immunotherapy.
Thank you, Harish. Am I audible?
Yes, you're perfect.
Yes.
Sir. Go ahead.
This gentleman with cancer has got acute on chronic kidney disease. Like any other patient in clinical nephrology, the same approach for acute exacerbation of chronic kidney disease has to be applied. The basic rules, starting from hypovolemia, obstruction, and detailed history, drug history, and so on. Here, there's no nephrotoxic drugs and so on. So the points in favor of immune checkpoint inhibitor associated nephrotoxicity in this patient is the timeline of onset of acute assault on the kidney, acute insult on the kidney, roughly about 3 months plus. So according to studies, the median time at which the AKI happens with immune checkpoint inhibitor is about 3 months. So that is number one. Number two, this particular patient has not been other nephrotoxic drugs like aminoglycosides or PPIs or NSAIDs. So that's the second point. And the other points like proteinuria, subnephrotic proteinuria, all that is very non-specific. The role of kidney biopsy in this patient, it is a bit tricky. Even though proteinuria is about 2, urine PCR is 2, and there is no concomitant nephrotoxic medications which can cause AIN and all that, there are 2 important factors that will make me a little bit hesitant to go for kidney biopsy. One is a high BMI. The other one, patient has been on apixaban. It has to be given due consideration whether is it worthwhile to withhold apixaban for the sake of doing a kidney biopsy. On the other hand, it occurs to me, why don't we just withhold immune checkpoint inhibitor for some time and then see. And one more point is that there is hypomagnesemia. I don't know why, what is the reason. This patient has been on cisplatin for quite some time ago. It was stopped. Sometimes what happens is that cisplatin induces a severe tubular injury that can lead on to kind of a permanent hypomagnesemia and so on.
Awesome. Thank you so much. I thought if there's one person who would notice a hypermagnesemia, it would probably be you. So thank you so much for that. So this I'm going to direct to Dr. Abudayyeh and Dr. Shaikh because I am going to ask about the biopsy question. But before that, do you use any non-invasive markers in your practice, or how do you look at UAs when you see such patients? Before you decide to go for a biopsy. How about Dr. Shaikh first?
Sure. So unfortunately, I would start off by saying, even though we use some markers, but there's none that has been adequately studied that shows good sensitivity and specificity for ICI mediated AKI or ATIN. Of course, using a general inflammatory marker, we use CRP that can be useful, although not always conclusive. There is a study from Mayo Clinic by Sandra Herman's group that showed measuring urine retinol binding protein and measuring retinol binding protein to creatinine ratio in the urine could also assist in the diagnosis of immune checkpoint inhibitor AKI. But one has to remember retinol binding protein is a non-specific marker of proximal tubular injury, and it's not available in most centers. You still have to send that out. It was the recent study by, and I will also add that TNF, serum TNF is also not useful in this situation, although we will talk about therapies, and Dr. Gupta mentioned anti-TNF therapies, but one has to realize that TNF alpha is a first of all, it has a very short half-life, so measuring it in the blood, you don't get a good sense of what it's doing at a tissue level. Although the urine markers that Dr. Gupta pointed out in AIN cases, non-ICI, AIN are elevated, but so that's not a very useful marker. And even though sometimes we use anti-TNF therapies, we don't guide our therapy based on serum TNF levels. And then, of course, a recent study by Megan Sai's group about the soluble IL-2 receptor levels, which is fascinating because we do that for non-ICI-AKI indications at MSK, and we know that it's a non-specific marker of T-cell activation. So how to use that level, when patients that we see have so many other reasons to have an elevated IL-2 receptor, perhaps it would be the degree of elevation as was shown in the study. We'll have to wait and see. And I'll also add that what method are you using to measure it also varies from center to center, which could change the level at which you would say, oh, this is predictive or diagnostic or suggestive of ICI-AKI. So I think, unfortunately, we use some of these markers, but at the end, we still have to rely either on our clinical judgment of how strongly we feel in treating someone as AKI due to immune checkpoint inhibitors without a kidney biopsy, if kidney biopsy is not feasible, and otherwise gold standard is a kidney biopsy.
Dr. Abudayyeh?
Yeah, I agree totally with my colleagues. I mean, they did a good summary. I mean, from our standpoint, it's very similar on our experience as far as these biomarkers. And as far as use of, I routinely, part of our algorithm here, order a cytokine 3 panel, which includes TNF alpha, interferon gamma, and IL-6. Again, it's hit or miss because the assay has to be drawn at a certain time, quickly delivered. It's very sensitive. It's not going to be as accurate if it's not handled correctly and placed on ice. So what I have done, what I found useful in these markers is in patients that, for example, have high TNF alpha, or I decide I want to use infliximab if I follow the levels for patients that do relapse after steroid taper, it has helped me a lot in guidance in redosing the infliximab. So I think with further studies and clinical trials, just like what Dr. Gupta was mentioning, and what we're planning to do is watch these cytokines in a lab kind of controlled environment to know how to follow those and how accurately are they going to be. But again, it boils down to our clinical sense. And in this case, especially, I mean, I wouldn't biopsy because of the high risk in, with the patients being on anticoagulation. And, if we do empiric steroids and it does improve, there's your answer in a way. And also not to hinder continuing therapy for the patient.
Harish, can I
Awesome.
make
Thank you so much.
Can I make
Yeah,
one
of course.
other
Go ahead,
point?
please.
So I think Dr. Gupta mentioned a very important point about concomitant or prior history of immune-related adverse events in a patient who presents with AKI due to immune checkpoint inhibitors. And when you are practically faced with a situation where biopsy is challenging or not feasible, you can certainly use that as a way to further strengthen your diagnosis if you are suspicious of ICI-AKI. The challenge that I have had is a lot of these patients, and not this particular patient that we are discussing, but a lot of these patients are on combined immune checkpoint inhibitors and TKI therapies. And one has to remember that the most common immune checkpoint related adverse event is colitis and skin manifestations. And unfortunately, TKIs also commonly cause GI symptoms and skin manifestations. I've recently had patients who come in on this dual therapy with a rash and AKI, and I'm trying to figure out which one is the cause of the underlying disorder. For one, we use steroids, for the other one, we wouldn't. And of course, biopsy would be useful. So I find immune-related adverse events very useful as long as the patient is not on a TKI, especially if I'm relying on dermatologic or GI symptoms as a co-marker.
Awesome. Thank you so much. Dr. Jhaveri, you had a comment?
Oh, I just wanted to comment that I've used all these markers as they've come out. I started using the Mayo markers initially, and they were very helpful. And then I started using the Megan Size markers, and I've started using combination of them. And sometimes having all of them sent out can also be useful. But I could say it's a 50-50 now with 3-4 years of experience using these markers. It's a hit or miss most of the time with these markers, including the IL-2 and the urinary studies of retinal binding. And I agree with Aisha that the most useful thing to me is the other itis on the patient. And that is the biggest clue to give steroids. And I agree with Ala about just empirically giving steroids and see if the response to the creatinine. You have to keep in mind the low, the centers that don't have these testings, it's hard to get these testings done in a timely fashion in most of the world. So I think it's useful to empirically challenge with steroids, low dose or even medium dose, and then kind of see where to go from there.
Great, all great points. Thank you. 50-50 doesn't really help at this time, does it? But I think there's a lot more work coming in. So, but I'm going to throw a little bit of a curveball here. So I will say that the IL-2 receptor in this particular case was like very, very high. I don't know how that will change your practice, but I'll move on to the next question. Is would you obtain a biopsy? I think you all answered this question a little bit, but I'll start with Dr. Goplakrishnan. You brought up the fact that this patient has high risk for a biopsy. You do have a non-invasive marker that may give you a little bit of a clue that this might be AIN. So at this time, your two options are treat with steroids, and if yes, how would you do it? Or you would still minimize as much of the other risk factors for biopsy and then go ahead with the biopsy. So Dr. Goplakrishnan.
Yeah. I think the IL-2 soluble IL-2 receptor levels are pretty high. The cutoff of 1.75 times the upper limit of normal, it shows more specificity, and so it adds on. It gives further clue that it could be immune checkpoint inhibitor associated with toxicity. So I think straight away we can withhold the drug for some time and then decide on steroid therapy. I wouldn't be too enthused to go for kidney biopsy, considering the patient being on a big survival.
But you also wouldn't treat this patient right now. You would hold and watch.
Yes, I mean, if there is a further increase in the serum creat, the serum creat is not just even 2 times, it's just about 1.5 times. So if it is on the increasing trend, I would like to start on steroids.
Okay, Dr. Shaikh, would you do the same?
I would start steroids. I think one of the things that we've learned is early initiation of steroids matters in terms of protecting kidney function and promoting renal recovery. Obviously, we are not sure if you're doing a biopsy or not. We can certainly stop the steroids if the diagnosis is not confirmed with a biopsy. One could argue that, if it's non-ATIN related AKI that just gets better with time, how would you know it? Did the steroid make a difference, or was it just improvement on its own? But this case has all the telltale features of immune checkpoint inhibitor ATIN. This is a significant enough bump in creatinine for me to protect the kidney function in a patient who already has some residual kidney dysfunction. So I would initiate prednisone sooner rather than later in this case.
Dr. Bansal, you had a comment? You're muted, sorry.
Sorry. So I agree. Suppose this patient is diabetic. Would you still consider starting, because many of these patients may be diabetic? So doing a biopsy is difficult in this patient, seeing her obesity, she's on anticoagulation, she's on PCN tubes bilaterally. So it's a difficult task. But whether it is a diabetic, because there could be multiple causes, and you are just assuming and based on this thing, but diabetic patient can develop other complication with the steroids, medium to high dose.
Sure, I mean, that has to be, sorry, go ahead.
No, go ahead.
I think Ala can answer that, because this is a question geared for her, and I don't want to talk.
No, you're fine. I think both of us would agree. I think definitely I would still treat the patient with the steroids, even if diabetic. There's really no reason not to just take care of the diabetes, either increase the insulin for a certain period of time, do whatever we can to mitigate the side effects of it. Honestly, I agree that I would treat right away based on the guidelines that are published from different societies, as Dr. Gupta mentioned. This is pretty much grade 2-3 toxicity, and the guidelines say hold immunotherapy, start steroids, and watch the patient closely. And if they're not responding, and that is, and I think I'm a big fan of this, of infliximab, but if the patient is having a hard time with steroids, we can always try to do a shorter course and then add infliximab. And I've had great results in the patients that are not tolerant of steroids. So there is a big movement towards biologics now in the immune related adverse events right now. So I think we really, as nephrologists, work hand in hand with the oncologists day in and day out. We need to look at what they're doing, because there's a lot of fascinating clinical trials where head-on are being used with combination immunotherapy before even adverse events happen. Just wanted to mention that, but yeah.
Sure. Yeah, all fascinating points. Dr. Goplakrishnan, I'm going to ask you a very quick question before I move on. Let's just say this patient's BMI was 30. Would you biopsy this patient? Or would you still empirically treat or hold immunotherapy?
So I would straight away start steroids, because there is no room to suspect any other cause for acute kidney injury in this gentleman. And doing a biopsy is technically difficult. So I would like to go ahead with steroid.
Okay. So yeah, this patient did have a kidney biopsy, but the BMI was not actually 48. I had it done for discussion purposes. But the apixaban this patient was on, and that was held peri-biopsy after verifying that the DVT was no longer present with ultrasound. The other thing I'll point out, that even in centers where the IL-2 receptor is commonly used, such as ours and Dr. Gupta's, that we still biopsy quite a few people, because I think the data is, we totally understand the limitations of the data, and I think it's important to point out that till we get to a point of being comfortable with the slew of biomarkers that are out there, if we can biopsy a patient safely enough, as Dr. Goplakrishnan mentioned, then I think we should, if we can, then we should do it. But I'm also not against the idea of empiric steroids. I think that is something that is commonly used, especially for milder forms of AKI. And most of these patients, you'll notice that it's not common for them to come in and say, hey, I had a bad hospitalization or severe diarrhea or the flu, and now I have an increase in creatinine. It's usually that they're asymptomatic, come into you with the rise in creatinine, and you suspect that this is almost always AIN. In other patients where there might be some other factors, that's when you think about like biopsy. Okay, so this patient's kidney biopsy showed diffuse severe interstitial nephritis, so the classical ATIN picture. And I think all of you mentioned steroids, but I want to get into the specifics, like what are the doses of steroids that you would use and for how long? I'll start with Dr. Goplakrishnan. Go ahead.
So I think in this patient, it's enough if we start with 0.5 to 1 milligram per kilogram.
And how long what would be a taper regimen? Would you base it on the creatinine, or do you have
based
a
on the
standard regimen?
serial creatinine, and if there is a drop in serum creatinine within 1 week or so, that's the favorable sign, and we can start quick taper.
Okay, Dr. Abudayyeh, any other comments?
I agree. What I do is usually the 1 mg per kg. I don't like to go too high with the steroids, and I typically taper off in a span of 3 to maximum 4 weeks. I actually go with the shorter taper, similar to the findings in Dr. Gupta's paper, where there was no difference in how long, in the patients that were tapered longer than shorter. And then watch for renal response, but always be vigilant, because these patients do relapse, where when the steroids either come off or down, the patients do relapse. The other thing I wanted to note for patients with difficult kidney biopsies, such in this scenario, another suggestion, something we published on, was looking at imaging. We have found that there is a difference in the volume of the kidney and then the PET CTs before and after nephritis, and those could indicate possible nephritis. So there's a side issue to consider in difficult cases to biopsy or solitary kidney.
Yeah, absolutely. So the one thing that I wanted to ask before is, I let Dr. Gupta, Dr. Shaikh comment on like what your duration of steroids is. I know there's a lot of variability based on how people do things, but I'd like to hear your personal opinion too before we move on.
Yeah, I mean, so this is my patient, so obviously I'm a little biased in this case, but just to sort of come back to this question about biopsy versus not. So there was a lot of discussion about this, and I do take into account patient preference, oncologist preference. So the patient, was a very, well-educated teacher, and he was like, I want to know exactly what's going on. I don't want to be empirically treated and not actually know. And the other issue was the oncologist said, this patient is having one of the best responses I've seen to immunotherapy. And so I didn't want to just commit this guy to steroids without actually knowing for sure. He didn't have any other extrarenal IRAEs. He wasn't on a PPI. He had this history of obstruction. He had a history of carboplatin and gemcitabine use. So there were plenty of other possible etiologies, and he had 2 grams of proteinuria and blood on his urinalysis. So it was not an easy decision, but if you do it safely, and especially in a patient where it's deemed safe to hold the apixaban for 10 to 14 days around the time of the biopsy, like in this patient, his reason for actually being on apixaban was simply that he had a DVT over a year ago. And when we actually got a repeat ultrasound, we did our due diligence. We got a repeat ultrasound and made sure that there was no evidence of that DVT anymore. And so, I do think the indications for anticoagulation matter. Like, let's say he had a fresh stent placed, in his heart a month ago. I probably wouldn't have biopsied him, because I don't want to hold the anticoagulation, for even a week in that patient. So I do think this is where, a case by case kind of basis really, makes sense. But I'll let Dr. Shaikh answer about how she would treat the patient.
So thanks, Shruti. So absolutely what other people said, we would start 1 milligrams per kilogram per day. I would definitely make the point that you should put these people on PCP prophylaxis. In the setting of AKI, you may not be able to do Bactrim necessarily, but we have used atovaquone, in almost all our patients when we do this. And the issue is not so much how quickly I'll start tapering. Of course, within a week, these people respond so fast that we start tapering it. The challenge that I've had is when they reach that 3-4 week mark and they relapse. And I sometimes have to go back up a little bit on the dose and maintain them on it. But if all is going smooth, 4 to 6 weeks is our general ballpark, but I have gone up to 6 weeks in some patients. And the key is you have to monitor them for relapse, and they could have a very good risk response initially. And when you're tapering the steroid dose is when you see the relapse happen. So my patients routinely go for weekly labs, and it's week by week basis that we decide what to do with the prednisone dose.
Absolutely. No, I think that's why I wanted to hear that, because we all have those patients who don't completely recover or have a small rise in creatinine at the time that you're almost stopping the steroids. And I think it's important to hear how everybody would approach that. So, this patient serum creatinine improves, but not totally. It does get down to 1.5 or 132. And the drug was held for a couple of cycles. And now, the cancer is maybe showing slight signs of progression. So the oncologist tells you that they would like to resume the drug. So I'm gonna ask you your thoughts. It's not like you're going to tell them do this or do that, but if they wanted your thoughts on it, what would you tell them? So Dr. Abudayyeh, I'll start with you.
Yeah, I would 1.5. It depends. This is how long after though, from treatment. It just, if it's something that's been a couple months after treatment and there's no further improvement, then I'll say go ahead and let's try, with potentially making sure they're not on a PPI or an NSAID or anything that could exacerbate this again. And if it's immediately after, I would say maybe wait and let's try infliximab, or let's try another short dose of steroid. Let's see where we can trend this further. And so that's kind of my thoughts, is it depends on timing, how long it's been since the insult and treatment.
Dr. Shaikh, would you do the same?
I would, and I think since we are short on time and this question comes up in so many sessions related to this, I think the people and oncologists sometimes are concerned about use of steroids and then dosing immune checkpoint inhibitors with this nervousness that would it impact the efficacy of the drug. So I don't want to belabor the same point, because I think instead of repetition, I would address that part, that I obviously would be happy to re-challenge this patient depending on his cancer response to therapy. That's priority with this almost complete recovery, though not complete, I would say, depending on how you define it, but it's close enough to his baseline. And if the response to therapy was great from a cancer perspective and there is a reason to restart, I would absolutely do it. I think Shruti made this point really well, that the risk of relapse is very low. Another point that I would make, and I think that was in the study that she published, is that baseline steroid of 10 milligrams did not lower risk of recurrence in these patients. So we don't routinely do that unless the patient's kidney injury was really, really severe and we are all really nervous about re-challenging the patient with it. And about the prednisone and the risk of immunotherapy, there's conflicting data. I will, however, say that the study from MSK, my center, that showed that 10 milligrams or higher dose of prednisone lowered the responsiveness to this therapy from a cancer perspective. Remember, those patients were PD-L1 naive patients. They had never been exposed to immunotherapy. That's a different beast compared to someone who's being treated for immune-related adverse events that occurred a few weeks or months after they had already been on this therapy. So, that's why you see conflicting results in different studies, but we don't routinely use steroids with re-challenge unless the AKI was really, really severe.
Oh, that's a great point too. And, it speaks to the next slide. There is some sort of data on re-challenging with steroids and the fact that perhaps there is a little bit of a decrease in ICI-AKI recurrence. As you can see in the different studies, the percentage of patients who were re-challenged on immunosuppression widely varied from anywhere between 30-40% to like 80%. And the risk of recurrence was low, but this is a highly selected population. We don't really know the exact circumstances of what the initial AKI was and whether re-challenging on steroids is the right decision to make. But it does make sense that in more severe cases, you would be thinking that even if the risk of recurrence is low, you don't want that patient to be on dialysis when they get re-exposed. So it makes sense to do that on a smaller dose of steroids. So, I'm going to ask a last hypothetical question that, let's say, you give 6 weeks of prednisone, you're now on like 5 or 10 of prednisone. This is the exact scenario you all spoke about. And would you do anything now? Would you treat this patient again, leave them be and accept this outcome? go back up on the steroids? What would you do? I'll ask Dr. Goplakrishnan first, and then we'll move on.
I think as per the published literature, there are experiences where addition of other immunosuppressants sometimes helps, ranging from azathioprine or MMF or even cyclophosphamide and so on. Apart from steroids, addition of immunosuppression is a choice in such a situation.
Dr. Abudayyeh, I think you've used infliximab. Would you try that in this patient or just go up on steroids?
I would probably also look at their UA. I'm not sure, like, I know there was proteinuria and hematuria, but in some pyuria, and the biopsy just showed acute interstitial nephritis and no GN. I would just repeat the urine analysis. I would give infliximab and a short dose of steroids in time for the infliximab to work and watch them. And the patient may, over time has scarred over, and it's not much there viable tissue to, recuperate from. But yeah, I would give it because, again, these patients are getting their cancer treated. We want to give them the opportunity to get the full effects of the immunotherapy. And that's Dr. Gupta mentioned, this patient had a great response to her immunotherapy. So we would hate for her not to have it. So we would do anything we can and always kind of caution the patient that we are doing the best we can with what we have, and ultimately your cancer treatment takes precedence right now with the least damage to your kidney as possible is what I would say. So I would give infliximab and maybe like a 5-day or 6-day dose of steroids.
Awesome, thank you for that. So, I'll get some take-home points, and I do want Dr. Gupta to summarize the second case we had because that has a couple of teaching points too. But as Dr. Gupta was saying, very few patients do get ICI-AKI, but it is a significant number. 2 to 5% is not something, that's on the high end of the spectrum in terms of frequency, but it's not low either. We didn't talk much about proton pump inhibitor use, but that's such a common medication, and so many patients are on it for very non-specific reasons most of the time. So I think that's an important medication to stop, and it does confer a pretty high risk of like AIN, and gives you an important clue to the diagnosis of AIN. And we spoke about kidney biopsies and non-invasive biomarkers, gene expression signatures are now coming along. So I think we'll have a lot more data about that in the coming years. And this is the point I think is very important. If you start the steroids early, I think most patients respond to it. And I think the response rate is so high when you consider like non-ICI drug-induced AINs. For example, if you have nafcillin-induced AIN, for example, I do think ICI-AIN patients respond really well. So I do think there is a good treatment for it. And recurrence occurs in less than 1/3 of the patients. So, and we don't really know if maintaining low-dose immunosuppression is useful versus not, but hopefully we'll get more data in the coming months to years about re-challenge on immunosuppression. Dr. Gupta did point out the thing about acute rejection that is so common in kidney transplants, but the data that is coming in really shows us that the initial thinking that perhaps you had to reduce immunosuppression was probably the wrong thing to do, and that can you hear me now?
Yeah.
Okay. And that you shouldn't really reduce immunosuppression if you can, but I think that data is coming up now that the initial thinking that you needed to reduce immunosuppression was probably not right. And we didn't really talk about this a lot. ICIs are not renally cleared, so their pharmacokinetics in dialysis patients is similar to the individuals not on dialysis. So there is a more of a push to include these patients in these trials and make sure that not just like any individual, but also our patients on dialysis are getting the benefit from these drugs for their cancer treatment. Dr. Gupta, I can go over the other slides and you can just like maybe summarize the next case, and we won't open it up for discussion, but I do think there's a couple of teaching points. So tell me next and I'll keep going.
Sure. All right, so this is a patient I saw a few months ago in clinic, a 63-year-old woman with metastatic adenocarcinoma of the lung on pembrolizumab and pemetrexed maintenance therapy, and she was coming to see me for AKI. Next. So she had previously been on triplet therapy with carboplatin, pemetrexed, and pembro, and then she was transitioned to the pemetrexed pembrolizumab maintenance. And her serum creatinine had risen from a baseline of 0.7 or 62 to 1.4 or 212. Her UA was totally negative. She did report a history of nonsteroidal anti-inflammatory drugs. She had no other extrarenal immune-related adverse events and no PPI use. Next. So sort of a trick question, but which of the following would you expect to see on biopsy? Could it be ATIN from the pembro, ATN from the pemetrexed, or ATN from the carboplatin? And this just basically is to sort of highlight that the answer is it could be A, B, or C, because these patients are on 3 potentially nephrotoxic medications. And, there are more results from these clinical trials like Keynote 189 that you can see here that shows that the addition of pembro to standard pemetrexed and platinum-based chemotherapy has really improved progression-free and overall survival, but AKI rates were higher in these patients than among patients who are receiving platinum and pemetrexed without pembro. Next. Now, pemetrexed, it's not a talk about pemetrexed, but it's important to remember the nephrotoxic potential of some of these other drugs. Like pemetrexed is an antifolate agent that is associated with a very wide spectrum of nephrotoxicity. And you can see here, these images actually show, interstitial fibrosis and chronic interstitial nephritis that you can see with these drugs. And unfortunately, this is not always reversible, and these patients can have progressive CKD even after the drug is discontinued. Next. And you all are well aware of the nephrotoxicity of cisplatin, which can also manifest as proximal tubular injury with ATN. And carboplatin is structurally related to cisplatin, but is probably better tolerated and less nephrotoxic and has comparable efficacy in these non-small cell lung cancer patients, which is why it's often used in the triplet combination therapy. So with this patient, tissue is really the issue. You really, really need to get a kidney biopsy in order to figure out what's going on. And basically on this low power view, you just see she has some mild to moderate chronic changes of her parenchyma. Next. And on this view, you can actually see there's a focus of interstitial inflammation in the center and at about 5 o'clock. And if you go to the next slide, on even higher power, you can see, again, there's a sea of lymphocytes and there are rare eosinophils as pointed out by this arrowhead. And so this was actually a case of acute tubular interstitial nephritis, and it was probably from the pembrolizumab. It was interesting because her urinalysis, again, was totally bland. She didn't have a history of proton pump inhibitor use, and she didn't have extrarenal immune-related adverse events. So these patients really do need kidney biopsies, and this is sort of a prime example of that. So she was started on prednisone, and she did have improvement in her kidney function, but she did not have complete renal recovery. And so this, cases like this led us to want to study, the role of triplet therapy combination and the incidence and severity of AKI in those patients, as well as the incidence of renal recovery. And so we looked at AKI in patients receiving pembro combination therapy versus pembro monotherapy using our Mass General Brigham cohort, as well as our international ICI-AKI consortium data. And interestingly, we found no difference in the incidence of AKI or AKI severity, and no difference in renal recovery, which was a little bit surprising. Again, this is an observational study, but I think it's maybe reassuring for our oncologists who are treating patients who are on all 3 of these drugs.
Awesome. Well, thank you so much. I think there was so much to learn from that session, and we look forward to more data, especially with re-challenge and especially in transplant patients as well. And thank you to our panelists for weighing in on the clinical management of these patients, and keep the questions coming in. We'll try to answer as much as possible while we move on to our 3rd session. So we are finally at the home stretch, and we have our 3rd session. Again, a super interesting topic that I really love and has been made really interesting by many faculty. One of them, we are lucky to have Dr. Jonathan Zuckerman, who after training at UCLA is an assistant professor in the Department of Pathology and Lab Medicine at the David Geffen School of Medicine at UCLA. He's also the service chief of renal pathology and residency program director. He has a passion for pathology education and enjoys sharing interesting and challenging educational cases through social media. He's also one of the most popular educators of ComCon, and he wins rave reviews every year for his deconstruction of renal pathology. We're so lucky to have him with us. If you want to follow him on Twitter, his handle is JZ Renal Path, and I didn't want to miss this opportunity to say he's truly the JZ of renal pathology. So welcome, John, and take it away, please.
Wonderful. Thank you very much for the kind introduction and the invitation to come and speak with all of you. It's a wonderful opportunity. So thank you very much. Can everyone see my screen?
Yes, perfect.
Wonderful. So today I'll be giving a brief overview of paraprotein-associated kidney diseases and monoclonal gammopathy of renal significance. I have a brief period of time, so it's really going to be a quick overview of the different lesions you can see on pathology that are related to paraprotein disease, and how we actually go about making a diagnosis on the biopsy. So paraproteins and monoclonal gammopathy. So paraproteins are abnormal immunoglobulins or part of an immunoglobulin that are found in blood or urine. These would be light chains, heavy chains, both fragments of light and heavy chains, as well as full intact immunoglobulins. And these are typically produced by a clonal population of B cells or plasma cells and can be associated with various types of plasma cell dyscrasias, such as multiple myeloma, lymphoplasmacytic lymphoma, or Waldenström's, sometimes just monoclonal gammopathy of uncertain significance, and can also be found in about 20% of B-cell non-Hodgkin's lymphomas. And usually these are the more indolent low-grade lymphomas, rare to see paraproteins with aggressive lymphomas. Now, hematopoietic processes and paraproteins can affect the kidney in a number of ways. And you can see kidney involvement both in the setting of overt hematopoietic malignancy, such as in the setting of myeloma or a lymphoma that's causing clinical symptoms. But we can also see kidney disease due to the paraproteins produced by these lymphoproliferative processes in the absence of overt hematopoietic malignancy. And in that setting, we classify these clinical pictures as monoclonal gammopathy of renal significance, where the underlying B cell or plasma cell clone does not cause tumor complications or meet any current hematologic criteria for any specific therapy, but there's kidney injury. And thus, there's a requirement of a renal biopsy for diagnosis, because the only way we can tell if there's paraprotein-mediated injury in the kidney is looking at it. And it's recognized that early recognition and treatment of the underlying plasma cell or B cell clone that's causing this paraprotein and kidney disease is important, as there's a risk for progressive kidney disease and end-stage kidney disease, and there's a high recurrence rate of these entities in the transplant setting. And in fact, I see not a insignificant number of cases where the patient never got a biopsy in the native kidney, and then in the transplant, that's the first time we actually identified that this patient had a paraprotein-related kidney disease. Now, I want to emphasize that monoclonal gammopathy of renal significance is not its own individual disease, but a category of related disorders. To make a diagnosis of monoclonal gammopathy of renal significance requires integration of the clinical findings along with the renal biopsy finding. The renal biopsy demonstrates and classifies the type of lesion, but nowhere in a pathology report is there going to be a standalone diagnosis of monoclonal gammopathy of renal significance. The diagnostic report will include diagnosis of the renal pathology pattern, which in correlation with a clinical finding can be confirmed as a monoclonal gammopathy of renal significance associated lesion. So for example, if we have, let's say, smoldering multiple myeloma, smoldering Waldenström's, a low-grade CLL, another low-grade non-Hodgkin's B-cell lymphoma, or just paraprotein in blood or urine, or sometimes no identifiable paraprotein, we see a lesion that we believe is secondary to monoclonal gammopathy in the kidney, then we can make a sort of clinical pathologic diagnosis of monoclonal gammopathy of renal significance. But it's also important to know that many of these renal lesions seen, in the setting of MGRS can also be seen with overt hematopoietic malignancies as well. So again, there's not going to be a single lesion on a kidney that's going to tell you the full clinical pathologic correlation. So you need both the biopsy and integration with the clinical information to actually get into this diagnosis of a monoclonal gammopathy of renal significance. So how do monoclonal proteins damage the kidney? There's two broad ways they do this. First is a direct mechanism, where there's some sort of monoclonal or monotypic paraprotein deposition within the kidney that causes injury. And that can be a glomerulonephritis, a glomerulopathy, tubulopathies, vessel injury, vasculopathies. And there can also be indirect mechanisms, where the paraprotein itself does not deposit in the kidney, but interferes typically with the alternative complement cascade and results in thrombotic microangiopathy or C3 glomerulopathies. So here's just some cartoons of how these direct mechanisms can work and how they can involve the kidneys in various compartments. So on the left side here, we have a cartoon that shows immunoglobulin deposition with inflammation or glomerulonephritis. In these situations, we have full immunoglobulins or fragments of immunoglobulins that deposit within the glomerular capillary loops. This is a cartoon showing a basement membrane in gray, the endothelial cell cytoplasm in orange, and then the podocyte foot processes in blue. We can see these immune complexes sitting in the subendothelial space, subepithelial space. These can be granular, unorganized deposits. They can be structured or organized. These will activate complement and induce immune system activation. So we can see here's some inflammatory cells coming. The inflammatory cells will secrete cytokines, proteases, et cetera, and cause damage such as breaks in the basement membrane and necrosis. And we see a glomerulonephritis pattern of injury. Now we can also see paraprotein mediated injury where there's just deposition of the paraprotein without inflammation. And these usually we call glomerulopathies or tubulopathies or things like that, where again, we have either light chains, light and heavy chains, which deposit along basement membranes of the glomerulus, or here's a tubule deposit along the tubular basement membranes or interstitium. And again, either in a unorganized or more organized fashion. But there's no inflammation that's necessarily induced, but there's marked structural abnormalities that interfere with the function of either glomeruli or the tubulo-interstitial compartment. And then lastly, we can see precipitation or crystalline formation of these antibodies or antibody fragments, either within a vessel, where you have, let's say, crystals resulting in thrombosis within vessels, within histiocytes, or within the lumen of tubules, or within the cytoplasm of tubules. So how do we actually make a diagnosis of a paraprotein-related kidney disease on a kidney biopsy? So number one, we need evidence of a tissue injury pattern. So we need evidence that the paraprotein is actually damaging the kidney. So that's a glomerulitis, glomerulopathy, tubulopathy, or vasculopathy. And we need evidence of deposition of a monotypic immunoglobulin produced in the biopsy for one of these direct mechanisms when you need typically immunofluorescence for that, or we see evidence of monoclonal gammopathy clinically with a known injury pattern associated with a monoclonal gammopathy in the kidney in the terms of one of these indirect mechanisms. So how do we demonstrate monotypic immunoglobulins in the biopsy? Well, we need immunofluorescence. And we have to demonstrate that there's either an intact immunoglobulin deposited with light or heavy chain restriction, or we can show a single light chain deposition alone, or a single heavy chain deposition alone, or a single light and heavy chain deposition. And this is, again, all done by immunofluorescence. And typically when we compare the heavy chain or light chain staining, we want to see at least a threefold greater staining intensity between the monotypic stain and the rest of the staining in regards to whether it's a kappa versus lambda light chain restriction or a heavy chain restriction. So now let's look at the actual injury patterns that we see with paraprotein-mediated kidney disease. So we'll start with those diseases that show predominantly tubulo-interstitial involvement. I mean, these include light chain cast nephropathy, light chain proximal tubulopathy, and crystal storing histiocytosis. So light chain cast nephropathy, I include in a talk about MGRS just to indicate that this is not an MGRS related lesion. If you see light chain cast nephropathy in the kidney, this is essentially a malignancy defining lesion typically seen in the setting of full-blown multiple myeloma. And these are situations where there's excess light chains being secreted by an underlying plasma cell or a lymphoplasmacytic cell. Those light chains get filtered into the urine. They form aggregates and precipitate with TAM horsefall protein, ultimately causing urinary obstruction as well as direct tubular toxicity. This typically presents as acute renal failure, and again, is the most common cause of acute renal failure in myeloma patients. And again, 90% of these patients either have overt myeloma or a heavy disease burden, lymphoplasmacytic or lymphoma, or another lymphoma with a marked plasmacytic differentiation. Now, what we see on the kidney biopsy are these so-called atypical casts. They typically show fracture lines, cellular reactions. They often show this two-tone blue and red appearance on trichrome stain, with the red being the immunoglobulin and the blue being the uromodulin or TAM horsefall protein they're precipitating with. They're often PAS negative, which can be your first clue you're dealing with an atypical cast. And then, of course, on the immunofluorescence, we should see restriction with one or the other light chain. In this case, we can see that there's kappa light chain restriction in these intratubular casts, and there's essentially no lambda light chain staining, and that clinches the diagnosis. Now, another similar but type of paraprotein-mediated tubulointerstitial disease is light chain proximal tubulopathy. And in this case, there's atypical light chains produced by a low-grade B cell or plasma cell clone. They have certain mutations within their VL regions that make them resistant to proteolysis. So these are secreted into the urine, and they're uptaken by the proximal tubule cells into lysosomes, but rather than to be degraded, they accumulate and ultimately crystallize, in some cases, in the cytoplasm of the proximal tubule cell, ultimately resulting in tubular injury. This may present as a rapidly progressive renal failure, or more often slowly progressive increase in serum creatinine. Fanconi syndrome may be present as these crystals interfere with the proximal tubule cell function. And up to nearly 100% of patients will actually have a detectable monoclonal gammopathy, and up to 33% may actually have multiple myeloma at time of diagnosis. So just to emphasize, as we'll see with some of these other disorders, this may be seen both in MGRS as well as secondary to overt hematopoietic malignancy. The biopsy features are often quite subtle in these situations, especially on light microscopy. We may see distension of proximal tubule cytoplasms with this kind of granular material, which corresponds to crystals. And typically, we actually pick this up on electron microscopy, where we see these large crystals within the cytoplasm of the proximal tubule cells. Of note, there is a non-crystalline variant where we just see these abundant, what appear to be protein resorption droplets by light microscopy. And then again, we see these abundant electron-dense lysosomes by electron microscopy. Occasionally, we see crystals within podocytes, and this can actually induce what's called a crystalline podocytopathy. And by immunofluorescence, we'll see restriction with one of the light chains in the tubular cytoplasm, either kappa most commonly or lambda, but we can see the restriction here. Interestingly, because of this crystalline substructure, the conventional frozen immunofluorescence is oftentimes negative, and we need to do a pronous digestion to so-called unmask this staining. Another related paraprotein disorder in the kidney is this crystal storing histiocytosis. So very similar to light chain proximal tubulopathy, we see intracytoplasmic crystals, but rather than being present within the tubules, they're present within histiocytes in the interstitial space. So here we can see a CD68 macrophage stain highlighting the cytoplasm of these interstitial macrophages, and we can see these large crystals in the cytoplasm of the macrophages. Here we can see the crystals on the toluidine blue stain that we use for electron microscopy survey sections. And then here's the crystals actually in a mesangial cell. And mesangial cells have some macrophage-like properties. Ultra rare disorder included in this presentation for completeness. So now let's look at some diseases caused by extracellular paraprotein deposition typically without an inflammatory response, and usually show mixed glomerular and tubular interstitial involvement. And these are amyloidosis and monoclonal immunoglobulin deposition disease. So amyloidosis results from deposition of misfolded light chains that form fibrils and typically deposit within glomerular basement membranes, mesangium, tubular interstitium, vessels, pretty much anywhere they want. The typical presentation is albuminuria and nephrotic syndrome, although if there's no glomerular involvement, the clinical presentation may be progressive renal insufficiency without significant proteinuria. Extrarenal organ involvement is very common and often will drive the prognosis in this disease, especially when there's cardiac involvement. And most patients will have evidence of a underlying monoclonal gammopathy. And again, 10% of these patients will also meet criteria for overt hematopoietic malignancy, multiple myeloma. In regards to amyloids we see in the kidney, the majority of them are immunoglobulin associated amyloids, and the majority of the immunoglobulin associated amyloids are light chain type, or AL. And this is what we expect to see on biopsy, is extensive, amorphous, slightly weak PAS positive material that fills mesangial regions. It can efface capillary walls. And typically it's negative on silver stain, as we can see here. The basement membrane is stained nice and black, and you have all these mesangial regions, which should be black, are actually not staining in this light pink color instead. Oftentimes we see these subepithelial spicules, or sometimes people call these eyelashes, and these are quite characteristic for amyloid. And again, the amyloid deposits can involve vessels. So here arterial walls completely replaced by amyloid, and also involve interstitial spaces. So here tubules are separated by all this pink fluffy amyloid material. The gold standard for diagnosis is the Congo red stain, where here we can see under polarized light, the positive Congo red deposits display aberrant colors, typically this green color, but can also be orange, yellow, sometimes blue. And we can actually also look at the Congo red stain under immunofluorescence using a Texas red filter, and actually will fluoresce in this channel. And then we can use electron microscopy to confirm that there's fibrils present, usually 8 to 14 nanometers. EM is not required, but it's nice to have, especially if the Congo red is somewhat equivocal. Now we can then type amyloid by using immunofluorescence, and typically conventional frozen immunofluorescence studies are sufficient for diagnosis of a light chain amyloid, where we'll see restricted staining for one or the other light chain. Here we have a lambda restricted staining of amyloid within glomeruli. But the immunofluorescence specificity is only about 92.4%. And occasionally we have equivocal cases, and we send those for definitive mass spectrometry-based typing. In general, the issue is mostly false negative, where there's just really no staining for the light chains. There are occasional false positive cases where you'll have what appears to be an AL amyloidosis, and at least in my experience, as well as what's been reported in the literature, oftentimes those cases turn out to be amyloid A. So if you have a good amyloid A immunostain and that's negative, and your IF studies are showing you an AL amyloid by light chain restriction, you could probably comfortably make that diagnosis without sending for mass spec. But at least in my practice, and because I have it available to me, at least through send out to Mayo Clinic, I have a low threshold for send out, since typing the amyloid will drive therapy. So now let's look at a related disorder of monoclonal immunoglobulin deposition disease. So in this case, there's aberrant light chains, or sometimes heavy chains, that are secreted by plasma cell or B cell clone. These are positively charged or glycosylated, and they can bind basement membranes, either glomerular basement membranes or tubular basement membranes, and ultimately cause structural problems and subsequent functional problems for those structures. Most patients present with proteinuria, nephrotic syndrome, renal insufficiency, and all these patients have detectable monoclonal immunoglobulins in their blood or urine. These can show extrarenal involvement, and up to 20% of patients have overt multiple myeloma at time of diagnosis. And these can be due to light chains, heavy chains, or a mixture of light and heavy chains. The typical pattern of injury we see by light microscopy is nodular mesangial sclerosis, looks very similar to diabetic nephropathy. Also see thickening of tubular basement membranes and can occasionally be associated with some tubular interstitial inflammation. We clinch the diagnosis on immunofluorescence, where we see linear glomerular basement membrane, mesangial, and tubular basement membrane staining with one or the other light chain, or a heavy chain restriction, or we can see both a light chain and heavy chain restriction. The electron microscopy shows this classic powdery deposits in subendothelial locations along glomerular basement membranes, as well as along tubular basement membranes. The last sort of major category of paraprotein-mediated disorders due to direct paraprotein deposition are those of the monoclonal immunoglobulin-associated glomerulonephridities. So this is glomerular deposition of a monotypic paraprotein, which results in inflammation. And this is an area that oftentimes causes a lot of confusion. So I'll try to sort of simplify this for you in saying that these are all very similar in terms of how you think about it, and that by light microscopy, there's going to be some evidence of a glomerulonephritis. And this may be a mesangial proliferative glomerulonephritis, an endocapillary proliferative glomerulonephritis, membranoproliferative GN or MPGN pattern, and sometimes membranous pattern. Then they will all show some sort of monotypic immunoglobulin restriction by immunofluorescence. And then by electron microscopy, they should all show some type of deposit. And then based on what the structure of the deposit is, whether or not there isn't substructure or there's a certain type of substructure, we can further subclassify this monotypic immunoglobulin associated GN into a more specific pattern, such as PGN-MID, or these other entities we'll talk about in a second. Most of these cases will show varying amounts of proteinuria and hematuria and renal insufficiency, and some of these disorders are associated with extrarenal vasculitides. So just kind of a generic case to give you a sense for how we make this diagnosis of a monoclonal immunoglobulin-related GN. Here we can see MPGN pattern injury with mesangial hypercellularity, endocapillary hypercellularity, and this lobular accentuation to the glomerulus. We can see double contours in the capillary walls that clinch the pattern of MPGN. We do our immunofluorescence microscopy studies, and we can see that there's IgG staining. And then when we look at our light chain channels, we see that kappa is negative and we have only lambda staining. So this is an IgG lambda monotypic process. Frequently, we also see varying amounts of complement activation, C3 and C1q, and we may see low levels of other immunoglobulins like IgM or IgA, but again, the difference is greater than 3 between the IgG and IgM. If we have an IgG restriction, we can do the IgG heavy chain subtyping to sort of prove that this is monotypic. So here we can do IgG 1, 2, 3, and 4, and in this case, this was IgG 3 restricted. Then we do our electron microscopy, and depending on what we see by electron microscopy, we can further subclassify this immunoglobulin, monotypic immunoglobulin-associated GN. For example, if we have no substructure in the deposits, into PGN-MID, or if we see substructure into one of the other types of GNs, in this case, immunotactoid GN. So let's talk a little bit about each of the individual glomerulonephridities. So proliferative glomerulonephritis with monoclonal immunoglobulin deposits, or PGN-MID, typically shows an MPGN pattern of injury, classically an IgG3 kappa-restricted immunofluorescence staining pattern, and again, only evidence of granular unstructured deposits by electron microscopy, and clinically the patient should have no evidence of cryoglobulinemia. Cryoglobulinemic glomerulonephritis frequently shows large subendothelial and capillary lumen deposits called hyaline pseudothrombi, highlighted nicely here on a trichrome stain, these bright red deposits. By immunofluorescence, oftentimes these are IgM kappa restricted. And the key feature by electron microscopy are these short paired microtubules ranging from 10 to 25 nanometers seen in subendothelial spaces as well as in these intraluminal spaces in the capillary loops. Monoclonal immunotactoid glomerulonephritis, also frequently MPGN pattern injury by light microscopy. The immunofluorescence typically shows an IgG1 kappa light chain restriction, and then classically the EM shows these long, somewhat parallel arrays of microtubules that are typically greater than 30 nanometers in diameter. Most of these patients will have an underlying hematopoietic malignancy, lymphoma, or multiple myeloma. And interestingly, even when we see this pattern of injury of immunotactoid deposition and it's polyclonal by immunofluorescence, many of these patients also have underlying hematopoietic malignancies or monoclonal gammopathy. Rarely we see monoclonal fibrillary glomerulonephritis, again, oftentimes MPGN pattern. Again, we see the restriction of the IgG and kappa. These usually will stain for DNA JB9 and show 10 to 30 nanometer fibrils in glomerular regions, as well as sometimes a tubular interstitium. Interestingly, if you try really hard to kind of prove that these are monotypic and you do paraffin IF as well as the IgG subclass staining, actually many of these apparent monotypic cases will resolve into polytypic cases and are not considered to be MGRS related lesions, especially if they're DNA JB9 positive. But there are rare cases that do maintain their monotypism, and we still consider them to be MGRS related lesions, although this entity may or may not stay in the subsequent classification schemes. And then the last type of glomerulonephridities that we can see with paraproteins are these crystocryoglobulonemic GNs. It's ultra rare, and this is intravascular crystallization of paraproteins resulting in endothelial cell injury, thrombosis, and inflammation. And here we can see the crystals in this glomerular capillary loop. So why do we try to subclass these monoclonal immunoglobulin mediated glomerulonephritises? Why don't we just call them all just monoclonal immunoglobulin GNs? Well, the different patterns of injury do have different clinical phenotypes associated with them. For example, type 1 cryoglobulonemic glomerulonephritis has a small risk of concurrent multiple myeloma, a large risk of concurrent lymphoma, although in some cases it's just a monoclonal gammopathy of renal significance. Similarly, immunotactoid also has a small risk of multiple myeloma, oftentimes associated with B-cell lymphomas, but again, sometimes is just MGRS related lesion, whereas PGN-MID very rarely associated with multiple myeloma or lymphomas, and almost always is a monoclonal gammopathy of renal significance. Interestingly, PGN-MID rarely shows detectable monoclonal proteins in blood or urine. Here it's quoted as about 30% of cases. In my experience, it tends to actually be less than that. Then let's look at the indirect paraprotein mechanisms in monoclonal gammopathy of renal significance, C3 glomerulopathy, and thrombotic microangiopathies. So we know that C3 glomerulopathies are associated with monoclonal proteins. Both C3GN and dense deposit disease can be seen. These tend to be in patients greater than 50 years old. 60 to 80% of C3GN patients have monoclonal gammopathy. About 30% of these patients show pathogenic paraproteins that seem to target complement factor H. And these paraproteins may also act as C3 nephritic factors and thus interfere with alternative complement cascade activity, ultimately resulting in overactivation and C3 deposition in glomeruli. It's important that one does pronase digestion on these cases, as apparent C3GNs in the setting may actually have masked monoclonal deposits. And then lastly, we may see thrombotic microangiopathies associated with paraproteins. It's been found that monoclonal gammopathies are present in about 21% of patients with TMA who are greater than 50 years old, which is higher than the expected general population frequency for MGUS. Low complement is seen in these cases. The mechanism here is poorly understood, but again, the paraprotein may be activating or interfering with complement activity, ultimately resulting in a atypical HUS-like clinical picture. And on biopsy, these just look like TMA due to any cause, and we can't necessarily say it's due to a paraprotein based on the biopsy, because again, there's no paraprotein deposited in the kidney. So with that, just some take-home points. There's a wide spectrum of kidney disease caused by paraproteins. They can occur in the setting of frank hematopoietic malignancies, low-grade lymphomas, and monoclonal gammopathies. Results from both direct and indirect mechanisms. And as you can tell, their characterization and detection requires robust immunofluorescence evaluation and careful immunofluorescence study. And then accurate characterization is important to understand associated risks for lymphoproliferative processes and systemic disease. So with that, I thank you for your attention and the opportunity to talk to you today.
Awesome. Thank you so much, Dr. Zuckerman. That was such a great summary of how to break down MGRS and to think about, so many distinct diseases or phenotypes associated with it. So thank you so much for your time and that awesome lecture. So to, follow that up with the clinical component, we're inviting Dr. Mayuri Trivedi to give us a lecture on a case of MGRS. She's a senior consultant and head of the Department of Nephrology at LTMG Hospital in Mumbai and a consultant nephrologist at Tata Memorial Cancer Hospital. She's the editor-in-chief for Kidney Columns for the Indian Society of Nephrology and an editorial board member for multiple journals and of ASN Kidney News. So welcome, Dr. Trivedi, and the floor is yours.
Thank you very much. I'm sorry. Yeah.
The slides are good. Thank you.
Yeah. Thank you very much. And since I'm the last lecture for the day, I'm not going to really waste too much of time. And we go on to the talk where I'm going to be describing a nephrologist's perspective, so a more clinical perspective about MGRS. And essentially, I'm going to cover the disease definition and then go and run you through a case and then discuss accordingly based on that case. So as we know, and as Dr. Zuckerman just kind of enlightened us, that monoclonal gammopathy of renal significance is essentially something which does not fulfill the criteria of a cancer, does not require immediate treatment, but at the same time, it does involve the kidney indirectly or directly because of the production of the monoclonal immunoglobulins. And if we have to really summarize this clinically, it is characterized by a kidney disease that really does not respond well to the regular immunosuppressive therapy that we use. And there is almost a 90% chance of this disease recurring post-transplant if the monoclonal gammopathy is not dealt with pre-transplant. And of course, the affected patient at any point of time has the risk of progressing to a frank corresponding hematological malignancy and therefore requires a monitoring probably throughout his life as far as MGRS goes. So if I had to kind of really tell you in a nutshell, MGRS is somewhere between the monoclonal gammopathy of unknown significance and smoldering myeloma and myeloma or Waldenstrom's or CLL. So now I'm not really going to speak too much about the classification of MGRS because we just had Dr. Zuckerman teaching us in detail about this. So let's go on to the case. So we have a 56-year-old male who was pre-morbidly absolutely healthy, and he presented with complaints that lasted since the last 4 months with easy fatigability, edema feet, and noticing froth while passing urine. On examination, the significant findings were he did have edema feet and he had a new onset of hypertension, and he did appear pale on examination. Now, the investigations that we ran on this patient, he had evidence of anemia. His urine routine microscopy was suggestive of a proteinuria 4+ with a microscopic hematuria, and he had a creatinine of 4.5 with a baseline creat of around 0.9 milligrams per deciliter 5 months ago. His urine protein quantification yielded 6.6 grams of protein in 24 hours. That was a nephrotic range proteinuria. And his sonography was essentially normal. The serological workup was negative with a negative ANCA, ANA, anti-GBM, and an anti-Cla2R antibody. And his serum complements were normal. So at this point of time, the clinical syndromic diagnosis was rapidly progressive glomerulonephritis. And the next thought was, of course, do we biopsy this patient? So a patient who presented like this would definitely, he had multiple reasons why he needed to be biopsied because it was a rapidly progressive glomerulonephritis with active sediments with nephrotic syndrome. But As we've seen in our previous sessions today, we need to balance the risk of underdiagnosis of a potentially treatable condition against the risk of bleeding in these patients. So the data essentially suggests that these patients do not have a higher incidence of bleeding, including the patients with amyloidosis on renal biopsy. And therefore, in case there is a high suspicion of a underlying monoclonal gammopathy, we should go ahead with a biopsy, especially in patients who are diabetics, to rule out a non-diabetic renal disease, or patients who are younger than 50 years, or patients who are a potential transplant candidates because these diseases are known to recur after transplants, or as in this case, there was an obvious evidence of an AKI and an RPGN with a rapid worsening of the GFR. So this patient on biopsy on light microscopy showed an MPGN proliferative kind of a glomerulonephritis with quite a bit of chronicity, with an IFTA of 30 to 35% with a moderate interstitial inflammation. The IF studies yielded an IgG3 and a kappa, so a light and a heavy chain staining, and the electron microscopy showed a non-organized deposit in the mesangial and the subendothelial region. So at this point of time, the diagnosis for us was a proliferative glomerulonephritis with monoclonal immunodeposits, that is the PGN-MID. Now, what next? What do you offer this patient? So one, we need to identify and quantify the M protein. Two, we need to establish the clone that has caused this deposition disease. And three, we of course have to rule out an underlying overt malignancy because this patient came to us with a picture that was suggestive of an underlying monoclonal gammopathy. So what are the tests that we can use to identify the M protein? The most common, most inexpensive quantitative assay that we all are commonly using is the serum protein electrophoresis, which can identify M proteins as low as 0.3 to 0.5 grams per deciliter. But we know that this is it's more useful for screening and may be useful for follow-up because it is the sensitivity is not too great, and it does not confirm monoclonality. So not really useful as a solo test in MGRS, because essentially MGRS is a low M protein condition. The next test that we can use is a serum immunofixation, which is a lot more sensitive as compared to the SPEP, and it can identify M proteins as low as 0.1 grams per deciliter, and it also confirms monoclonality, but it is essentially a qualitative test and not a quantitative test. So usually not useful for follow-up, but we will have to do this test when we have to prove complete or partial remission in these patients. The other test we use commonly is the serum free light chain assay, a normal value of 0.26 to 1.65. But we need to remember that these assays do get affected by renal dysfunction, and therefore the range for a patient with an underlying renal dysfunction would be a little higher, a 0.37 to 3.1. Though it does not confirm monoclonality, it is useful in screening as well as follow-up because it is a quantitative test. And the high ratio suggests a kappa clonality, whereas a low ratio would suggest a lambda clonality in these patients. And of course, a urine protein electrophoresis and immunofixation, though not very easily available, and it is useful for a low M protein state like MGRS because it is quantitative as well as defines monoclonality, so can be used for screening and for follow-up. The next step in this patient would be a bone marrow biopsy to identify the clone, and it has to be performed in every patient of MGRS because it would rule out the underlying malignant process also. We may get away without a bone marrow biopsy in patients in whom we are suspecting CLL, the lymphoid clones, or a CLL underlying as the disease, because this can be proven with a peripheral smear also. And the bone marrow is going to help you quantify the percentage of plasma cells or the presence of atypical lymphoid or lymphoplasmacytic aggregates. It will also identify an underlying amyloidosis, the AL amyloidosis in these patients. Plus, we can also have specialized tests like the flow cytometry, immunophenotyping, for detection of minimal residual disease, cytogenetics, and genetic evaluation, which is more important in those with the malignant process, and the myeloma FISH studies. Now, what if the bone marrow biopsy is negative? A very common picture that we would see, especially in patients who have a PG and MID kind of a picture. We may go ahead and perform an imaging study for these patients, which can be a contrast-induced CT or a PET CT or an MRI, which may diagnose a plasmacytoma, or if the patient has a lymphoid clone, may have lymphadenopathy, which can help us get the biopsy material, and it may diagnose an underlying lytic bone disease, which may point more towards a malignant process. And there are specialized tests which are not too easily available in our country, which is the next generation flow cytometry, which are useful for picking up low M protein states where the tumor burden is extremely low, typically in MGRS. So the clone detection rate, as we see, the clone detection rates are highest. The high likelihood is in light chain cast nephropathies, as well as in the light chain proximal tubulopathies and the light chain varieties of PJ and MID. The diseases which are very essentially defined under MGRS, there is a variable likelihood of clone detection, and more often than not, we do not have an underlying clone that can be identified. So what would be our approach to MGRS therapy? We need to realize that most patients with MGRS do not have a life-threatening condition unless there is an extrarenal organ which is affected, which is commonly seen in the AL amyloid kind of MGRS. And the primary treatment objectives in patients of MGRS is to preserve kidney function rather than life, because these are not life-threatening conditions. So we have to balance the risk of treating these patients versus the benefit of therapy. So essentially, if the patient has advanced kidney disease or is a CKD stage 5 or an ESRD, when he comes to a nephrologist, at that point of time, the treatment is directed towards reducing the risk of recurrence of MGRS post-transplantation rather than reversing the disease, because the patient has already become an ESRD. And if this patient has advanced CKD with no chance of transplant, we need to treat only if extrarenal involvement or a malignant process is involved. Otherwise, treating a patient with MGRS with no chances of transplantation does not really make too much of meaning. And clone-directed therapy is what is the norm, and that has been found superior to just empirical immunosuppressive therapy in patients with MGRS. So the treatment strategy will depend upon what is the isotype of the underlying clone, most commonly an IgG, very less commonly an IgA or only the light chains versus IgM clones, which really don't do very well. What is the underlying renal function? As I said, advanced CKD without extrarenal involvement in a patient who does not have any hopes of a transplantation really does not make too much of meaning. We need to know the potential renal toxicity of the therapy that we are going to offer. And obviously, a lot of these drugs may have renal metabolism and may cause a worsening of the renal functions if used. And if this patient has presence of underlying neuropathy already before treatment, because the drugs which are used for the treatment of MGRS as well as monoclonal plasma cell dyscrasias do have a neuropathy as a very severe side effect. So the endpoint of therapy here is complete elimination of the monoclonal immunoglobulin in case the patient is going ahead with a renal transplant. This is ideal, but at least the aim should be substantial reduction or at least a very good partial remission in these patients. So good partial hematological response is defined as difference between the involved and the uninvolved free light chain assay, that is the kappa or the lambda, should be less than 4 milligrams per deciliter. And there has to be at least a 90% reduction in the involved free light chain levels as compared to pre-treatment. So once we have identified the clone, the therapy options that lie with us is, apart from obviously the supportive measures, which would be a good anti-proteinuric. If this patient is proteinuric, you start the ACE inhibitors and the ARP, salt restriction, the diet regimen, which we would use for any patient with CKD, irrespective of what the native kidney disease is. So apart from this, as I said, the therapy has to be clone-directed therapy. So if the clone workup shows a B-cell clone with IgM, the treatment of choice would be a rituximab or an anti-B-cell therapy based regimen, a clone workup showing a plasma cell clone with IgG, IgA, or light chains would essentially be treated like with an anti-plasma cell therapy base, so a bortezomib or a daratumumab, which is an anti-CD38 monoclonal antibody, or if the patient fits into the criteria an allogenic stem cell transplant, and if the clone workup is negative, which we see in a large number of patients with MGRS, especially with patients with, like our patient, the PG and MID kind of a patient, you would start an empirical therapy targeting B cells and try and see the response for the next 3 to 6 months. And if they don't or they progress, would empirically give them also the plasma cell directed therapy. So for no clones, it would be completely shooting in the dark with an empirical therapy, supportive measures, and empirical therapy targeting B cells and the plasma cells. So coming back to my case, the further testing, as expected, the protein electrophoresis was negative, the immunofixation was negative. Remember, PG and MIDs are low M protein burden diseases. And the serum free light chain assay was slightly raised at 1.83, but that did not make us wiser because this patient had a deranged renal dysfunction. We went ahead with the bone marrow biopsy that thankfully showed us 5% of plasma cells. That again fits into the fact that he did not have an underlying malignant process going on. And therefore, at this point of time, an hematologic referral was taken and the patient was started on a dexamethasone, bortezomib, and a cyclophosphamide-based regime, which is the most common regime used in monoclonal gammopathies, which are because of plasma cells. And the creatinine did reduce to 2.8 milligrams per deciliter over the next 3 months. And the proteinuria also significantly reduced to around 1 gram from 6.6 grams. And at present, after 8 months of follow-up and therapy, this patient continues to remain at the same state. So of course, we could not, kind of treat him completely, but he is in partial remission. And at least from a dialysis requiring state, he has come down to being a CKD stage 2-3. So I'm going to end my lecture with the following take-home points, that essentially MGRS is a relatively new term. The definitions have come out as late as 2012, and the concept is also equally late, and we are all learning, so it does appear to be intimidating. And essentially, the aim for MGRS is, you improve the outcomes of this disease because it does not fit into the definition of malignancy. Clone-directed therapy is justified and it aims at renal function preservation and prevention of recurrence post-transplantation. Therefore, I again reiterate that if a patient has come with advanced CKD or ESRD, we are not justified in giving this patient clone-directed therapy, because it is the aim of the therapy is not saving the life, but aims at renal function preservation. And lastly, we of course require to work as a team along with our hemato-onco team and our colleagues there, because together is what we need to treat this disease, even though it is not a malignant disease. Thank you very much.
Thank you so much, Dr. Trivedi. I think that really highlights how, we've moved on to this whole clone-directed therapy, but even then there might not be even answers and the patient may not respond. And empirical therapy, of course, may not work. So I think there's so much to learn about these diseases in the coming years. So thank you everyone for weighing in. On to Dr. Bansal for any closing thoughts.
Yeah, so thank you, Harish, for moderating. So I would say overall, this was a very good session. Means that so all the talks were really great, and all the panelists and speaker did very good job. So on the behalf of organizing committee, I would just extend my vote of thanks to everyone who made this conference webinar a grand success. So obviously my heartful thanks to gratitude to Harish and Khenar, who actually arranged all the faculty and made the program of the webinar, and as you can see, it was very well made. Additionally, Harish moderated it so well and engaged the audience till the last, and we can see till the end more than 150 delegates were still there, and all the speakers and panelists who did a very insightful presentation and presented their research work. Dr. Shruti, Dr. Rimda, and Dr. Khenar, obviously he started the session, and Anuja, everyone, thank you very much for your time and your effort to make it possible. And I would like to sincerely thank all the delegates who were there till the last and who actively participated in the meeting, in the question and all of them, I'm sure, are benefited by this webinar. So, and in the last, our partners, Meetings and More, who provide an excellent platform for this meeting. And I'm sure, Harish, Khenar, would you like to comment? Means this has been excellent collaboration between Indian society and American society, and we would like to do it further, extend these sort of meeting with your help, of course.
No, thank you, Shyam and Harish. And I think on behalf of the American Society of Nephrology, I think sincere thanks to the Indian Society of Nephrology for doing this combined session, and hoping that there'll be ongoing seminars, we can collaborate and learn from each other.
Thanks a lot. Thanks everyone again, once again. So we have some excellent photos to share. I'll share with Harish and you, and we can put it on media, social media. Thank you. Thank you, everyone.
Okay, bye-bye.
Bye-bye.
Thank you.
Thank you. Thank you.